Good.
He's not in the camera.
No, yes, there's only one camera for all of us. You have 1:1 camera, but we all in one.
Good.
Yeah, all in one camera.
This hall we are all there.
Yeah.
Yes.
Yeah, and
So Dr. Lata is there.
Doctor. No,
Lata is not there. Our organizing committee, Dr. Prachi is there, Assistant Professor of Biotechnology, a former my postdoc. She is there, Dr. Prachi.
Okay.
She is Dr. Prachi. She will actually moderate all the things. And I am there to see everything goes smoothly. And our PG first year, Dr. Smita is also there.
I mean, what time? 2:30?
2:30. Now I think it will be starting.
So another 2 minutes we'll start.
No, mine is will start at 3:30. Huh? It has changed.
Okay.
3:30.
3:15 I think.
3:15 I'll go.
बाहर रहना अभी स्टार्ट होगा. So tell me when I will start.
You attend this.
Kusalda.
And Paul, please tell me.
There will be vascular.
It's in the auditorium.
Iqbal,
Yes.
okay. We are audible?
Yes.
Okay, fine.
Yes, Kusalda. You are all audible.
Bas, that's what we wanted to confirm. Fine, thank you.
नहीं आता है.
So 2 minutes, I'll be back.
Kushal will be chair. Kushal will come to this side.
अच्छा सर আমি ওদিকে চলে যাচ্ছি.
He will come in this side because he will chair. No?
Laptop.
So in this session, Dr. Machado will give a talk.
No, after him,
After him,
next is Dr.
so there are 3 speakers in this.
Okay, next one.
Yes, Shankar.
Yes, Shankar. हाँ.
नहीं but
Machado.
Give hands.
प्राची इसमें स्पीकर का नाम क्यों नहीं लिखे? टाइटल से क्या होगा? कौन बोल रहा है उसका नाम नहीं है तो?
हाथ से लिख दो, हाथ से.
If I use the two things, then what is the meaning? It should be same place.
हाँ.
Name and speaker.
नाम हाथ से लिख दीजिए अभी.
हाथ से सब स्पीकर का नाम लिखो.
So there are 3 speakers here. Machado, T.S. Shankar and Alam.
Yes, Shankar, because that's short. He's a very senior, 88 years old.
Okay.
He still exists, working.
Working.
He bypass also work and he come here. He's a visiting professor of medicine of our university.
Okay.
Dr. P.S. Shankar. P.S. Shankar is 2 times B.C. Roy Award.
So award.
And in MCI he was inspector and he was a postgraduate council member and
Okay.
chairman long back. 86-year career, 88-year career.
88. Commendable.
Recently UNESCO on my initiative felicited him.
Okay.
One of the most distinguished professor
Okay.
of medicine in the world.
Okay. Congratulations. Very nice. Commendable.
Almost 15 to 20 international top professor, in my request they join.
Okay.
We felicitate him. It's a great, and Rajiv Gandhi University of Health Sciences Emeritus Professor of Medicine, lifelong. He's MD, DSc, I think 6 or 7 university, delete from 2 to 3 university, nothing else. And FAMS as you well, and also FRCP, I think all 5. He loves me like anything. almost like a son. He used to be. Still, our medical students, he comes and take class.
Mm-hmm.
Sit there.
Okay.
His book is there, no clinical physiology one, clinical examination one book is there. P.S. Shankar book,
Okay, P.S. Shankar.
published from Delhi. That book is once upon a time very popular in our when it's and
Function
now
analysis.
there is a practical. 1965 he has written. We can start now. Machi? We can start. हाँ, एक कागज का लिख रहा है क्या?
गया नाम तो लेके गए ना
हाँ, जल्दी जल्दी जल्दी।
3 नाम लिखो सरनेम
मैं
लिखो
लिख के नाम बोलो मैं लिख लेता हूँ।
राइट डाउन सरनेम so we can find out from the titles itself.
अमित घोष में
You need to go to auditorium. You need to chair.
हाँ अच्छा अच्छा अच्छा।
Okay, thank you.
Not now. It is 3:30.
Yeah, 3:15.
I know
3 people. His time is there.
again 10 minutes again.
Yes.
He manages 40 years in the.
We have 10 minutes, right?
Yeah, 10
I'll
minutes.
tell them.
Okay.
अरे यहाँ में कोई पीजी को भेजो।
यहाँ पे सर?
एक दूसरा कोई है तो देखो। घूम रहा है यहाँ।
उसका नाम अमूल अमृत अमृत
He is in Moradabad near to you.
স্যার আমার কথা কিছু নেই তো তাহলে ডাকতো নিশ্চয়ই
You can move roam around anywhere. Those are responsible. I have taken the name of speaker and this is important for me. I don't know Dr. Deepak, I don't know you, don't require you. Professor Iqbal. Professor Iqbal.
No, it's good. Ah,
Good afternoon. We are going to start now. Otherwise, it will delay.
Amar sir is also visible.
Yes. And
গুড
I like to inform you that our time is very short. It is only 20 minutes plus 5. Okay.
हाँ प्रॉक्टर साहब हाँ वो कर देंगे
So
नहीं तो मैं फोन करके बोल दूंगा अगर नहीं है तो
नहीं है वो
अभी मैं मीटिंग में
I request you to maintain the timing.
मीटिंग ये
Start.
सफीक
No, we are going to start now. These things used to be. How will you be reading?
So many good.
हाँ तुम अभी नाम बुलाओ तुमको नाम बुलाओ चेयरमैन को नाम बुलाओ इसको मैं इंट्रोड्यूस करता हूँ एक माइक वहाँ है ना You sit there.
But
Otherwise,
normally these mics are good, they can pick up from anywhere.
Yeah, that's a very good high.
May I start, sir?
Start.
Good afternoon, one and all. Good afternoon, sir.
इंटरनेट नहीं जा रहा है क्या?
Go on.
Sir, am I audible, sir?
कुछ इंटरनेट प्रॉब्लम है क्या?
Hello, sir.
হ্যালো
You are muted.
Okay.
Sir,
Welcome, Professor P.S. Shankar, sir. Dr. Kushal Das. And former Dean of All Institute of Medical Science, Professor K.K. Deepak is here.
Okay, fine, sir. Namaskar.
Physiological Society of India's President, Professor Amar K. Chandra of University of Calcutta.
Fine.
And today's the speaker will be from Delhi, and chairperson is from here. He is Dr. Prashun Naik, a professor of physiology from AIMS, Jodhpur.
Fine. Fine.
Thank you, sir.
नमस्कार
Thank you, sir.
good afternoon, sir.
Now go ahead. They are will
Yes. May I start? Good afternoon, one and all. So now we will start our online scientific session. The first session will be is of Dr. Mohammad Iqbal sir. He is a professor of Jamia Ahmad, New Delhi, and this session is chaired by Dr. Prasun Kumar Nayak sir, AIMS Jodhpur sir. Now I request Nayak sir to please head this session.
You may close the room.
Good afternoon, everyone. Hello, Professor Alam.
Yeah.
Yeah. So it's my pleasure to introduce Professor Alam. He is Professor Head, Department of Physiology, Hamdard Institute of Medical Sciences and Research, Jamia Hamdard, New Delhi. He has obtained his master's and doctoral degree from Department of Physiology, University of Calcutta. He has served as chairman and professor in Seva University, Department of Physiology in Libya. He has total altogether he has 30 years of teaching and research experience in the field of physiology, pharmacology and drug discovery. Many research funding agencies such as ICMR, CSIR, DBT, DST projects have been he has completed successfully. Many national and international recognitions are already with his credit. He is also awards from different reputed organizations like INSA, UNESCO, DST, CSIR and UGC. Dr. Alam also has got membership from National Academy of Medical Sciences. He is also a life member for Indian Science Congress Association, Indian Pharmacological Society, the Physiological Society of India, Association of Physiologists and Pharmacologists of India. He has made significant contribution in research and development in India and abroad by bringing prolific innovation in the area of genomes and toxins. He has visited and presented several of his research papers in different countries like France, Turkey, Australia, Malaysia, Iran, US. His research area includes genome and toxins, drug discovery, and cardiovascular system. He has also already contributed around more than 100 research papers in national and international peer-reviewed journals with high impact factor. So we have Professor Alam here. He is going to talk about exploring the diagnostic potential of inflammatory markers in preeclampsia. So it's all to Professor Alam. Please continue.
Okay, thank you for the introduction. A warm and gracious afternoon to all of you. So I'm honored and really humbled and happy to be presenting a paper entitled Exploring Diagnostic Potential of Inflammatory Markers in Preeclampsia. As we all know that preeclampsia is one of the hypertensive disorder of pregnancy, and it is a major cause of maternal and perinatal mortality, number of stillbirths and death that occurs in the newborn of the first week of life and the morbidity. So hypertensive disorder of pregnancy occur in about 10% of all pregnant women around the world. So pregnancy that affects 3 to 5% of preeclampsia that affects 3 to 5% of all the pregnancy. And in India, preeclampsia is reported to be 8 to 10% among the pregnant women in India. So, slide. So, and it is the major contributor of maternal and fetal morbidity and mortality. So preeclampsia can also lead to life-threatening conditions like eclampsia and affects many other organs, mainly liver, kidney, and also the brain. So preeclampsia that patients are at risk in future if they survive, then the future risk is on the cardiovascular system. So here, in the present talk, we are discussing and comparing the preeclampsia in animal and the human. And we have identified some of the inflammatory markers that affects and that may lead to a diagnostic tool for the identification of the preeclampsia. Now, the preeclampsia, we know about the pathophysiology of the preeclampsia. What about the pregnancy, the poor placentation, spiral arteries modeling that leads to spiral arteries modeling, and then this spiral artery modeling that leads to the sterile inflammatory markers that increase huge, that mainly the HMGB1. And HMGB1 also, you can see that the preeclampsia that affects the endothelial dysfunctions. Then there is an decreased nitric oxide production, and the decreased nitric oxide production that leads to the placental hypoxia. This also leads to increased HMGB1 or the sterile inflammatory markers. So all of these that activates the neutrophil and then increase the neutrophil lymphocyte ratio. So this neutrophil, so this is that leads to preeclampsia, and then if it is treated, then it's a good, or if it is not treated, then that leads to eclampsia. So now the clinical types of preeclampsia, we know that there is a mild and the severe types of preeclampsia. So the mild, we know that it all depends on the blood pressure, that is systolic and the diastolic. And also in the severe, that all leads to proteinuria, the decrease in the platelets counts, and then the health syndromes that occur in the preeclampsia. So what are the symptoms mainly that occurs in the preeclampsia? So the high blood pressure, that is, if it increases beyond 140/90, then there is a protein in the urine, then the swelling of the hands of the face. Then the patient that always complain about the headache, and then sudden weight gain, seeing the spot of the vision changes, stomach pain, especially in the right upper side. Then also there is a leads to there is a complaint of nausea and vomiting. So the clinical feature of preeclampsia, we are dividing the signs and the warning signs and the mild symptoms. And as per the classification or the clinical features of the preeclampsia, the warning signs that are the severe headache, blurred vision, nausea, vomiting, excessive swelling, and decreased urination, and the rapid pulse rate. So all these that leads to the formation of sterile inflammatory markers. So how the sterile inflammatory markers that occurs and that form in the preeclamptic patient. So these preeclamptic patient that increase. So this is the background of the preeclampsia. I'm not going details about this background, but that's all we can say that it may be due to the genetic predisposition, abnormal immunological response, deficient trophoblast invasion, and hyperperfused placenta. And then this all leads to the endothelial dysfunctions and the abnormal hemodynamics that reduce uteroplacental blood flow. And this decreased uteroplacental blood flow leads to the constriction of, it is because of the constriction of the arteries, and that leads to the formation of sterile inflammatory markers. So, and this is the screening test. I'm not going, because all we know that what are the tests that we and how we can identify the preeclampsia. So the regular and what are the prophylactic measures of preeclampsia? There's a regular antenatal checkup, antithrombotic agents that we are using, heparin, calcium supplements. We are giving antioxidant and the nutritional supplements and the balanced diet. These are all the prophylactic measures of preeclampsia. And then what are the complications that occurs because of this if these are not taken into account? So the abruption of the placenta, cerebral edema, edema occurs. That also leads to the pulmonary edema, laryngeal edema, acute respiratory distress syndrome, sepsis. These are all the complications that leads that is because of the preeclampsia. You can see here some of the points that I have given. Then what are the curative measures that we are taking? So delivery of the fetus is one of the important curative measure. If the fetus is delivered, then the placenta, then the preeclampsia is over. But after delivery in the preeclamptic patient, still there is a high risk of organ disorder because of the high concentration of sterile inflammatory markers that are remain in the blood, and that if these sterile inflammatory markers that increase after the delivery of the fetus or after the curative measures that we are taking, it still affects the other organs, mainly the cardiovascular system. So these are all you can see that the organ that affects because of the preeclampsia. It not only affects the uterus, it affects the placenta, it affects the liver, kidney, and also it affects the cardiovascular system mainly, and also brain and lung. So what are the role that the main focus that earlier we have published 2-3 papers in connection with the nitric oxides, the role of nitric oxide in the preeclampsia. So even though these are all the established that we have also established that what are the role of nitric oxide in the different organs and the different organs of the body, and we identify and then we publish this data in Elsevier and Nature. So these are that we have done the explain about the functions of the nitric oxides in the preeclampsia and what they do and how they affect the preeclampsia. So I'm not going in details because this is today's my talk is mainly on the sterile inflammatory markers, and we have identified which of the marker that plays an important role in the preeclamptic patient, and that we have identified these both in the animal model and the human model. So, the poor placental association with the hypoxia, oxygenation, that all leads to the sterile inflammatory markers. So these sterile inflammatory markers is because of the stress or high level of the oxidative stress or the low level of the nitric oxides formations. So now you can see the level of, and then this data is the human data that we have taken the patient's blood and the patient's sample from our hospital record, and we see that what happened when there is an preeclampsia and what happened when there is an and we compare with the normal patients or normal delivery, that pregnant patient or the pregnant subjects. And then we compare with the nitric oxide level in the plasma of the rats and the clinical samples that we just comparing with the two species, that is the human and the animal. And you can see see that in both the cases that there is an increase pregnancy control. You will find that there is a normal level of nitric oxide, and in case of the preeclampsia, there is a decreased nitric oxide concentrations. So also we see the NLR ratio, that is the neutrophil lymphocyte ratio in both the cases, that is in case of the animal and in case of the human sample. So we also see that these two in the preeclampsia, you will find the ratio is increased, the NLR ratio increased. So these are all the published data, and we are just showing you that in both cases we compare both in case of the animal and in case of the human subjects, this ratio changes abruptly and in proportionately. So other changes that occurs in the biochemical parameters when we have taken the other parameters, that is hemoglobin, platelets count. You can see that platelets. We also see about the creatinine, GOT, GPT, and then glutathione, uric acid, alkaline phosphatase. All these data that are comparable with the animal model. But in some cases, in animal model, we will find that there is a changes in the in the say for example in hemoglobin or in it is not comparable, but in glutathione also it is not comparable with the human sample. But in case of GOT, GPT, and alkaline phosphatase and the uric acid, they are all similar train. The changes in similar manner that affects both in preeclamptic patient and also in the animal model. So, and this is about the sterile inflammatory markers in the pathophysiology of preeclampsia. You can see that the extracellular DNA, you can see about the extracellular RNA, you can see about the HMGB1, the VWF, von Willebrand factors, you can see decorin. These are all extensive studies we have done in both the animal model and as well as in the clinical subject. And you will find that it is very comparable that all these inflammatory markers, they are deranged in both the cases, in both in human samples as well as in the animal model. We are comparing this and we have published this data in Nature's in scientific report. I'm not going details about it because you will find that eDNA, eRNA, that is extra cellular DNA, RNA, our main target, and HMGB1. So HMGB1 is main culprit that these molecules, they are the main player that leads to stimulates the other inflammatory markers. So we are doing this mechanism of actions and we establish that the HMGB1 is one of the culprit that increase in when beyond the starts of the preeclampsia. So this is one of the markers that leads in a preeclamptic patient that leads to increase the train of both in the animal and the human subjects. So and then in patient, we characterize the other factors also. The gestational age we have seen, but it is not possible in the in the animal model. Proteinuria, lymphocyte neutrophil, platelets count, gestational age at the time of delivery, and the blood sample after delivery. So we compare both the gestational age at the time of delivery in the animal model and also in human, and the blood sample after the delivery we have taken, and we see that what happened in the healthy pregnant and the preeclamptic patient and also in the animal model. Then we see about the expression of neutrophil elastase. This is also one of the important factors that affects during preeclampsia. So this is our this expression of neutrophil elastase we have done in human subject, not in animal model. And you can see that in normal pregnant and in the preeclampsia, you will find that there is an increase extracellular neutrophil elastases that are coming out from the nucleus. They are all the extracellular we have seen under the electron microscopy, and also we have done it in the FACS. Other is, you will see the expression of VWF. We also you can also see that there is a huge increase in the concentration of you can see here in the concentration of VWF in the preeclamptic patient when we compare with the normal patient. So normal it is very less expression of VWF, but in case of preeclamptic patient, you will find there is a huge increase of VWF in preeclampsia. And also, if you see that there is an increased expression of HMGB1. So now you see that in preeclampsia, HMGB1 is expression of HMGB1 is very much when we compare with the control sample. So you can compare with the HMGB1 concentration in both the cases. That is, when we merge about the DAPI and the HMGB1, you will see that there is a very less amount of HMGB1 expression here. But in case of the preeclampsia, the expression in both the cases is too much. The HMGB1 here, it is very high. When we merge with the DAPI, you can see that there isn't high concentration or expression of the HMGB1. So this is about the decorin. So decorin also, you can see the expression of the decorin is increased. So these are all the animal human data, not the animal data. So we are just showing this data that there is a high concentration or high expression of this HMGB1, neutrophil elastase, decorin in preeclamptic patient. If we compare if we compare with the normal preeclampsia. So these are all the biochemical parameters. You can see these are this is about these samples are in the human samples. So you can see the blood urea, serum, creatinine, alkaline, GOT, GPT, and proteinuria. So other is the platelets. You can see that the platelets counts also, and the NLR ratio. These are all in the normal and in the pregnant preeclamptic patient. So there is an so to summarize this, that this project is sponsored by Grand Challenge Canada, and they have given us to identify the sterile inflammatory markers so that we can develop the diagnostic kit. So we identify two molecules first. Then we identify that the specific is the HMGB1. So, HMGB1 is the main culprit. We are doing the mechanism of action of this, and we are on the verge of identifying that how this HMGB1 is expressed in preeclampsia and how we can counteract the expression of the preeclampsia. So to summarize this, the preeclampsia is an amplification of the inflammatory response that is physiologically present throughout the pregnancy. And nitric oxide is associated with the vasodilation during pregnancy. And preeclampsia is linked to the deficiency in a reduced reactivity in nitric oxide. So reduction of nitric oxide level may be utilized to diagnose the preeclampsia. Earlier we are identifying it, but now we change it, and then we identify more specific that the sterile inflammatory markers, that is HMGB1, decorin, VWF, neutrophil elastase, and heat shock protein, HSP1, HSP17, HSP19. They are all deranged in the preeclampsia. We have not showing these results, HSP90 and HSP70 and HSP100S. These molecules also, they are deranged in both the cases, in the human sample as well as in the animal samples. This study have focused on the pivotal role played in the oxidative stress, inflammation, specific sterile inflammatory markers in the etiology of preeclampsia. So moreover, this investigation introduced the concept of utilizing neutrophil lymphocyte ratio, decorin, and as a promising diagnostic indices for the evaluation of the severity of the preeclampsia. So now we link the increase expression of the HMGB1 and the decorin. So HMGB1, that directly or indirectly they affects the expression of the decorin. Then, so we can conclude that the expression of sterile inflammatory markers in both the samples, if in the preeclampsia of both human and the animal samples, they are all deranged. NLR ratio also significantly increased in the preeclampsia. So decreasing the trend in the all sterile inflammatory markers when the pre and the post delivery samples of the preeclampsia, we also seen that after delivery we are seeing that the inflammatory marker decreases, but not so much that that comes in the normal range. So therefore, it can be deduced that the NLR, decorin, and the HMGB1 is most of the important molecule which plays a significant role in the pathophysiology of as well as the progression of the preeclampsia. So this is our group that we are working here. They are all the PhD students. So Huma Kasmi, she is working in ICMR project in animal model of preeclampsia. Poonam, he's working in GCC project of preeclampsia. The Seema Wajib, he's working in Ayush project that is also is sponsored by Ayush. He's also working in preeclampsia. So Neha, he's working in some other projects. Yashasvi and Aditya, they have joined recently. Aditya is working in the preeclampsia that is we are we are using the metformin for the treatment of preeclampsia, and this project is also sponsored by ICMR. So thank you so much for the time you have given. So this is one of the small works that we are comparing with the animal model and the human model of preeclampsia.
And the
Now-
mic.
Thank you. Thank you, Professor Alam. It's a nice presentation, and it appears it's a long work, but you have made it short, and it's nicely presented. Questioning will be available there.
I think that
One or two we can take
one
it.
question, or maybe somebody wished, but
Actually, I have a small query. I would like to know how you develop the animal model of preeclampsia.
Yeah, it's a good question. There are different models that are established. We develop by using the L name. So
L name.
we block the nitric oxide. We're using the L name, and we are giving the L name at the 11th day of gestation to the animal. So we give 7 days of L name. Then on the 18th or the 19th day, we sacrifice the animal. So we have established this because if we delay or we wait for the 21st day of gestation of rat, then we will see that on the 19th, maybe 19th, 20th day, the delivery occurs. If the delivery occurs, then the preeclampsia model all the sterile inflammatory markers, they are all decreased. So we injected 7 days of L name. It starts from the 10th day of gestation of the rat till 18th day. And the 19th day, we sacrifice the animal. And then we see that what is the status of the fetus and how the fetus develop. So we have a lot of observation in the fetus. And we have a histology of that. We see even the fetal, what happened to the fetus, how many fetus are there. So it's very interesting. So some other times when we will publish the data, then we will present.
Yeah, that's what I was about to ask you, that when you have an animal model, you can really
We have developed it. It's very difficult to develop model. So I asked Kusalda also when we started this work on preeclampsia. It's a long back, 5-6 years back, but now it's a established model, and we are developing other model also of preeclampsia.
I'm saying that fetus part, you can see the developmental scale, developmental challenges what they are facing, the fetal level. The mother
Yes.
part you are seeing, so both
Mother and the fetus, they are all the fetus. In preeclamptic fetus, the number of fetus decreases. You see, in normal pregnant, if you see that the pups are 7, 8, or 9 pups, but in preeclamptic animal, you will see the 3, 4 fetus, and the fetus, if the fetus is there, they are all abnormal fetus. So legs are there, heads are not there. So there is a huge, you see, problem in preeclampsia.
Anyway, thank you. Any other question? Anybody would like?
Next time, next.
Anyway, thank you. It's a very good presentation.
Thank you.
Catch him. Physically, when Dr. Iqbal will come, then all will catch him physically. And when we'll go to your
No, I have a plan to join you there, but unfortunately, our examination of first prof is going on, and it's very difficult to leave the department at this moment. You know, 102 batches going on, and the
Everybody is
that
facing
is the
this.
problem.
the
There is
same.
a two batch, first year's two batch we have.
Yes,
It's the
yes.
first time.
All of
All
us
the
we are
faculty
facing this
are
same problem.
involved here in teaching as well as in the examination.
Suffering for 400, 500 students at a time for
Public attack
months.
problem.
9 months teaching.
You have same problem.
Anyway, thank you very much.
Thank you.
Thank you so much for giving me the chance.
Very good.
Dr. Iqbal, it is a fantastic presentation, and we should see you here in physically, number one. Okay.
Next time we will sure, I will sure, we all come, at least 4 or 5 people we will come from our department.
But for just to visit, you can come here. Just to visit the BLDE and our vascular lab, you please come. Okay. You are
Okay.
always welcome with the students, and we are cordially welcoming you, the entire Hamdard Institute of Medical Science students for the first year physiology as such concern, and faculty members. Now I tell you that we are sending your citation in due time by email. Okay.
Okay, thank you.
Okay. Thank you very much. Thank you. We can go for the next session.
Well, it would have been better if you would come here. We become too much happy. And
It's because of the commitment of the department.
We know that.
And it is also your responsibility to come here, as I do remember. But you have some official responsibility, so how you can avoid it? Okay. Have a good
Okay, thank you.
We're happy to see you.
Okay. Thank you, Iqbal. Thank you,
Thank
Dr. Okay. Now invite the
Okay, Kisan.
Professor P.S. Shankar, sir.
Yes.
Uh,
Yes, sir,
sir,
I'm here.
Yeah, Professor Dr. P.S. Shankar, sir, your face is not visible. No, your face is not visible. Yeah, you have come. Sir, Professor Shankar, sir is with us. It is a great honor. Sir is 86, 87 years old, the oldest professor of the medicine of this state and also India. And his immense contribution is, I think that no doubt to speak about that. He got all the national and state award, including twice B.C. Roy Award from the Medical Council of India. And Professor Shankar is actually the living legend and god for the medicine we consider entire India. He was an MCI member and very old. And Professor Shankar is a MD and also DSc. For at least 6 universities, he is DSc. He is a DLIT and 5 university, 5 medical, so Royal College, he is a fellow. He's a first CP from 5 Royal Colleges. He's a legend as such, we can say. Nothing more than that I should tell about my mentor and guru, Professor P.S. Shankar. I just putting you namaskar and pranam to you and bestowed my respect and all our. We are having here Physiological Society of India President Professor Amar K. Chandra, UGC Emeritus Professor.
Namaskar from our side. We are honored to have you among
Thanks,
us.
sir. Thank you.
And your chairperson of the session, Dr. Prashun P. Professor of from AIMS, Jodhpur. Sir, you are a great honor because UNESCO has felicited you with a lifetime achievement. So I have nothing more to say about you. Sir, I think I over to Dr. Prashun P. Nayak.
Good afternoon, sir.
Well,
Good afternoon, everyone. Our next speaker, as already Professor Das has mentioned, Dr. P.S. Shankar, sir. He is MD, FRCP, already we have seen DSc, DLIT, has been Professor of Medicine for 60 years and Administrator of Medical Colleges as Principal, Dean, Director over 30 years, author and editor of 240 books in English and Kannada, including Medical Encyclopedia, an English Medical Dictionary and an English Kannada Science Dictionary. Sir, I am honored that I am chairing your session.
We are there, but you are there to chair Professor Shankar's session. Okay. Sir, your time is 25 minutes and 5 minutes I wanted to keep it for interaction with you. So it is 25 minutes talk.
Professor Shankar is a recipient of Dr. B.C. Roy National Award twice by MCI, Government of India, as an eminent medical teacher, and as an orator, gifted Teacher Award of API and Master Teacher Award of Indian College of Physicians, India. He is also the recipient of Karnataka Rajyotsav Award, Sir M. Visweswara Senior Scientist Award from Karnataka government. For his lifetime contribution as medical teacher and philosopher, UNESCO conferred him certificate D honor, that is certificate of honors. Sir, I think this is a small paragraph to try to hold your enigmity.
Yes, we should not speak.
So, and sir will be talking about applications of nanotechnology in medicine. Sir, please.
Thank you very much. Thank you very much, sir. Professor Kushal Das, distinguished faculty, delegates, postgraduates, and ladies and gentlemen. It's an honor for me that I am speaking in the galaxy of physiologists. So the topic is application of nanotechnology in medicine. So nano devices we all often refer to, utilizing the technology, very small machine tools, they could be produced and introduced into the human body to undertake the cellular repairs at the molecular level, a variety of anatomically precise microscopic instrumentation, and advances in the field of nanotechnology. They have made significant impact in all scientific fields. So the medical diagnosis, monitoring, and treatment at the level of single molecules or molecular assemblies, they providing a structure, control, signaling, homeostasis, and motility in the cells of nanoscale of 100 nanometer or less. The application of nanotechnology to medicine utilizing the molecular tools and the molecular knowledge of the human body. So it is possible to provide therapy at a molecular level and improve the human health by utilizing the molecular tools and the molecular knowledge of the human body. So it helps in better understanding of the pathophysiology of different diseases at the molecular scale and the dynamic behavior of abnormally functioning cellular machinery. So it enables to provide specific treatment of the diseases with the miniatured medical tools will provide more accurate, more controllable, more versatile, more reliable, faster approaches to enhance the quality of the human life. So drug delivery system is one important role. The development of newer methods based on the nanotechnology. They are used in the treatment of cancer, diabetes, viral infections, fungal disorders, and in gene therapy. The advantage of targeting the drug to the site of the disease and increase the safety profile. So diagnostic procedures by using the contrast agents, fluorescent dyes, and magnetic nanoparticles. So these new drug delivery system with a nanostructural delivery architecture, it has shown promising results to deliver the drug to the specific targets. It's capable of sustained release of drug. Nanoscale drug can enter the cells and act locally without exhibiting any toxic effects. It's likely to affect the etiological condition of the disease and bring about the relief to the patient. Richard Feynman. So the emergence of new technology. Nano, in the Greek, it means dwarf, 1 billionth of something. This nanomedicine, prediction by the Nobel physicist Richard Feynman in 1959, he made a statement. There were no fundamental physical reasons that materials could not be fabricated by maneuvering the individual atoms. He made one statement which everyone will talk. There is plenty of room at the bottom. There is plenty of room at the bottom. He proposed using the machine tools to make smaller machine tools. It can be used in turn to make still smaller machine tools and so on, all the way down to the atomic level. He visualized it is a development which cannot be avoided. So utilizing this technology, very small machine tools, they could be produced and introduced into the human body to undertake cellular repairs at the molecular level. Can undertake a variety of atomic, precise microscopic instrumentation. It deals with structures of 1 to 100 nanometers scale. The advances that have significant impact in all scientific fields. The technique has potential medical applications. So nanomedicine, which we are concerned today, the conventional drug therapy suffers from major limitation of adverse effects due to the non-specificity of their action, improper dosage, it affects their efficacy. It is possible to design the drugs with greater degree of self-specificity and provide therapy at a molecular level. So the nanomedicine is bringing about a change in the methodology by which drugs and sustained release preparations can be delivered. It provides targets the drug delivery, improves the efficacy, and minimizes the adverse effects of the drug. So tools are developed to take images of structures at a molecular level and to undertake high-speed measurement of the molecular assemblies. So the devices which we are considering now, one of the important device, the nanoporous biocapsule. They are tiny chambers that can be created within a single crystalline silicon wafer containing biological cells with a surface perforated with very tiny holes or nanopores as small as 20 nanometers in diameter. So this allows small molecules such as oxygen, glucose, and insulin to pass into the surrounding biological environment. It does not allow the entry of larger molecules such as immunoglobulins and cells into the chamber. The nanoporous membrane appears like that. So these nanopores are able to make immunoisolation. They enable encapsulated rat pancreatic cells to receive nutrients and remain healthy for weeks. They are able to secrete insulin and allow its passage through the pores while remaining hidden from the immune system. So nanopores can be utilized to protect transplanted tissues from the host immune system while retaining the benefits of the transplantation. So it has a place in the treatment of type 1 diabetes mellitus. Nanosieves is another important thing. It is possible to regulate the flow of the material through the nanopore by utilizing an artificial coated gated molecular nanosieve. They contain tiny tubules of an internal diameter of 1.6 nanometer. The positive charging of these tubules excludes positive ions and facilitates the transportation of the negative ions through the membrane. In presence of a negative voltage, only positively charged ions pass. These voltage-gated nanosieves are able to control the transportation of the ions such as enzymes, antibodies, and other proteins. So nanosieves appear in this fashion. Nanoshells is another important device. Nanoshells, it offers a platform for the nanoscale drug delivery. Made of gold-coated silica nanospheres, it can be embedded in a drug containing tumor-targeted hydrogel polymer. Then can inject it into the body. It will concentrate near the tumor cell on heating with infrared laser. From a source outside the body, these nanoshells selectively absorb a specific infrared frequency, melt, and release the drug at a specific location. So they exhibit the thermoablative property. So they may be utilized in the treatment of diabetes mellitus, where the injected nanoshell polymer can release a pulse of insulin on heating the skin using a tiny infrared laser. Such a system can stay in the body for several months and it takes away the need for regular injections of insulin several times a day. The same approach is being made in the treatment of micrometastasis. Fullerene-based pharmaceuticals, they are another important thing. These fullerenes, also referred to as buckyballs, are the carbon allotrope, soluble derivatives of the fullerene having 60 carbons, Buckminster. They are arranged in the shape of truncated icosahedrons. They can find a place in pharmacotherapy. They exhibit biocompatibility and low toxicity. They can act as antiviral agents, antibacterial agents, antimitotic agents, antioxidant, and anti-apoptotic agents. So the metallofullerene and the empty case fullerene, both of them are kept side by side. Tectodendromeres. the single core tree-shaped synthetic molecules. They are formed within a regular branching structure, dendrimer, to which several dendrimer modules are attached, each of which is able to function as a therapeutic nano device. They can recognize disease cells, their location, and drug delivery and report the response. Chemotherapeutic releasing dendrimer molecules. They are attached to the core dendrimer. They can be made to recognize the cancer cells, release the cytotoxic agents to destroy such cells specifically without affecting the healthy normal cells. So dendrimer, the core unit, the branching dendron, and the surface ligand is shown here. These dendrimers, they can replace conventional viral vectors in gene therapy, which we are commonly using the viral vectors. So they enter the cells by endocytosis, where the DNA gets transported into the nucleus for transcription of the applied gene. They do not stimulate any immune reaction. They have found a place as contrast agents in imaging. Nanosomes, they act as probes encapsulated by biologically localized embedding. Pebble are being utilized for diagnosis and the therapy of the brain tumor. Polyethylene glycol coated silica nanoparticles, along with targeting the antibody and the contrast gadolinium, are used to access specific areas of the brain affected with the tumor. Binding of the nanoparticles specifically to the tumor cells with the targeting aids and contrast helps in proper delineation of the growth with MRI. Later, laser can destroy the cells loaded with these nanoparticles by heat generated by iron oxide following absorption of the infrared light. So the structures of nanosome, this appears in fashion. Nanobubbles, nanoscaled bubble-like structures, they are utilized to incorporate anti-cancer drugs. They remain stable in room temperature. They get coalesced to form microbubbles when heated to physiological temperature within the body. So they are able to target the tumor tissue and deliver the drug selectively under the influence of the ultrasound exposure. So it enables an increased uptake of the drug by the tumor cells, such as doxorubicin. Disruption of the microbubbles leading to release of the drug, they get concentrated in the target cells. The nanobubbles at the surface between the hydrophilic silica and the water, they appear in this fashion. Quantum dots, very important things. They are 2 to 10 nanometer sized nanocrystals, which can be made to fluoresce on stimulating by light. They consist of an organic core, an inorganic shell, and an aqueous organic coating. Biomolecules are conjugated. They are as highly sensitive probes after tagging with biomolecules. Quantum dots conjugated with polyethylene glycol and antibody, the prostate-specific antigen PSA, they are able to get accumulated in the prostate tumor tissue. They are used to image the sentinel node in the cancer. They will enable the stage the tumor and guide the treatment regimen. Quantum dots have been distributed here. Nanotubes, they are tubular structures like sheet of graphite rolled into a cylinder, capped at one end or both ends by a buckyball. These carbon tubes may be single-walled or multi-walled. They possess greater strength and stability. Hence, they can be used as a stable drug carriers. Carbon nanotubes are made more soluble by incorporation of carboxylic or ammonium group to their structure. They can be used to transport peptides, nucleic acids, and other drug molecules. Amphotericin B nanotubes are able to provide an increased drug delivery to the interior of the cells. Single-walled nanotube appears in this fashion. Biorobots, they're engineered bacterial biologic robots. They are constructed from 300 highly conserved genes at a functional microbe. They can be made to produce vitamins, hormones, enzymes, or cytokines that are found in lesser amounts in the human body. They can be made to absorb and metabolize poisons, toxic substances into harmless end products. Biorobots. Respirocytes. It is an artificial mechanical red blood cells, a spherical diamondoid nanorobo. It is able to deliver 236 times more oxygen to the tissue per unit volume than the natural red blood cells and to maintain the carbonic acidity. They possess sensors on the surface which can detect changes in the environment. Onboard nanocomputer helps in regulation of intake and output of oxygen and carbon dioxide molecules. So these respirocytes function similar to that of natural hemoglobin filled with red blood cells. So they may replace transfusible blood substitutes. An infusion of 1 liter of 50% respirocyte saline suspension, they can keep the patient oxygenated up to 4 hours. The respirocytes, they are microbiome. It is an artificial mechanical white blood cell capable of destroying hematogenously distributed pathogenic microbes. These spheroidal nanorobots attracts the microbiological pathogens which get bound to the surface of the microbiome. Then they get internalized and minced and discharged into the bloodstream as amino acids, fatty acids, nucleotides, and sugar. So they are likely to function as efficient and fast-acting phagocytes and may eliminate the septicemic infections at a faster rate than the natural defense mechanism with using antibiotics. The microbiomes and the red blood cells. Liposomes, which we are all using nowadays, the original models of nanoscale drug delivery device are in use over 4 decades. They are the earliest examples of the nanoscale drug delivery device. Spherical nanoparticles consist a lipid biolayer membranes with an aqueous interior. They may be unilamellar with a single lamella of the membrane or multilamellar with multiple membranes. They are used as effective drug delivery systems, more efficient and safe as compared to conventional preparation in administering anti-cancer drugs, amphotericin, and hamicin. Liposomes can be loaded with water-soluble drugs in the aqueous compartment and lipid-soluble drugs in the lipid membrane. The water-soluble drug in the hydrophilic core and oil-soluble drug in the lipid bilayer. So these modifications can be used to target delivery. Chromosome replacement is a nanorobot controlled chromosome replacement is a cytosurgical procedure where chromosomes can be extracted from a particular diseased cell and insert new ones in their place. A chromosome has to be produced outside the patient's body using the patient's individual genome as a blueprint. So the replacement chromosome is demethylated so as to express only the appropriate exons that are active in the cell type to which the nanorobo has been directed. So the chromosome replacement therapy, how it can be utilized. In conclusion, nanomedicine is able to create a nanomachinery of living cells and control and manipulate these molecular and supramolecular assemblies in living cells, combat disease states, and improve the health of the individual. Nanotechnology has raised great hopes in medicine and many potential benefits have been visualized. However, the safety of nanomedicine has to be worked out. Nanomedicine will play in the coming days a crucial role in the treatment of human disease in the years to come. Thank you.
Thank you very much, sir. It's really it's a hectic, mind-blogging presentation. It's so nice. Actually, it's a vast topic, and you made it. It's a really I appreciate that. And in this context, sir, I'm not dare ask you any question or anything.
Yeah, I think that Professor T.S. Shankar sir, who has 60 above years of experience of teaching as a professor of medicine in India, so no question should be asked. He has been given the highest honor by the UNESCO Lifetime Achievement.
Thank you.
So I
Thank
think we are honored, and because you have spoken at the age of 88, this is a blessing to us.
Sir,
It's a blessing to us.
I have a request, sir.
Ah.
Sir, I am working as chief editor for Indian Journal of Physiology and Allied Sciences.
Yeah. I
Can-
also edit the journal, Rajiv Gandhi University Journal. I'm editing from the past 13 years, and the Science Journal of the Science Academy from 17 years. I'm an editor.
Sir, can I request you to publish this paper, review paper in our journal?
So I will send it.
Thank
I will
you
send
very
to
much, sir.
Kushal
I
Das,
shall-
and I'll definitely
I
do
shall
it.
share the email of Professor Nayak. I shall share the email, and PSI also I will share the email to you. So thank you very much.
Thank you very much, sir.
Sir,
Thank
your
you for the
cit-
opportunity given to me. Thank you very much.
sir, your citation will be sent by email to you. You are nothing to citation, say you are citation. Just as a token of respect.
Thank you.
We
Your
missed
good
you.
words, affection, I am very happy. Thank you.
Sir, we missed you in this conference. You supposed to be here because of a
Yeah,
certain health
I know.
we understand. But you recovered that. We are very glad, and we are going to see your long life, further long life. Stay with
Thank
us
you.
and bless us, sir. Thank you,
Thank
sir.
you, sir.
Thank you. Pranam, sir. Next speaker, you have to come.
Next speaker, I think there will be next chairperson. So I wish to thank organizing committee to giving me this opportunity, and that particularly with Professor Shankar and Dr. Alam, obviously. So thank you very much for organizing committee and Professor Kushal Das. So that's all. Thank you very much.
Please.
I come.
एक कोई फोटो एक फोटो लो जस्ट take a photo. Please, Rajan.
1 minute, sir. Kusalda, please.
Thank you very much.
Nice session. Chairman, good. Speakers were also
Thank you
strong.
very much for your comments, sir.
Both the speakers were potential speakers.
Now I think I think you have to invite the next chairperson. Sudipta is visible. Only Sudipta, you have to look at the speaker. Dr. Arijita from IIT Kharagpur.
You come here. That will be better.
Good afternoon, Ajita ma'am.
You can come a little closer, otherwise voice will not be there.
Can you able to hear us?
অরিজিৎ কেমন আছো?
Hello?
Hello.
Come here. We will not hear your voice.
Hello, am I audible?
Hey, you are audible. Arijita, you are audible.
I'm audible?
Yes.
You
You're audible.
Arijita, you are audible.
অরিজিতা
Yes, sir. Yes, sir.
Oh, fine.
চিনতে পেরেছো?
হ্যাঁ স্যার কেন চিনতে পারবো না
তোমার কি কলেজ স্টার্ট হলো?
এখনো স্যার হয়নি বোধহয় এনএমসি
হয়নি?
পারমিশন এইবারে তো ডিরেক্টর লেগে আছে
আচ্ছা হবে?
মনে তো হচ্ছে
আইআইটি খড়গপুর জয়েন করেছে কুশলদা।
Are I was his assistant, her assistant.
হ্যাঁ তুমি ছিলে।
I was the member. Achha, welcome Dr. Arijita Banerjee. We are very proud because she is a proud alumni of this institution. This is the most important thing. She is a proud. So we are inviting now the proud alumni of BLDE Medical College, the BM Patil Medical Dr. Arijita Banerjee, and he will be introduced by the chairperson, and I like to tell that she is now currently assistant professor at the first medical college under IIT at Kharagpur.
Yes.
So we are very proud of Arijita. You are doing very good, and I'm personally happy. So now I think Dr. Prachi will do the formal intro.
I welcome you, ma'am, Archita ma'am, and this session will be chaired by Sudipta ma'am, and I request Sudipta ma'am, please proceed with this.
Dr. Sudipta Pal from Tripura University, Agartala.
First of all, Arijita, I must congratulate you for your such a nice achievement. And I have heard for just now from Kushala that you are the alumni of this institution also. So good to see you. And um as per the norms, I have to just briefly introduce you. So Dr. Arijita Banerjee received her DNB and MD in physiology. She was attached to various institutes like PGIMS, Rohtak and Maulana Azad Medical College, Delhi for residency program. Currently, she is working as assistant professor in Dr. B.C. Roy Multi-Speciality Medical Research Center, IIT Kharagpur, India. She is also faculty in NPTEL under Ministry of Education, with her currently running courses like electrophysiology of heart and basics of mental health. Dr. Banerjee has an interest in neural control of cardiorespiratory function with an emphasis on the characterization and origin of the naturally occurring discharges of sympathetic and phrenic nerves. She is a recipient of various awards and has published articles both on national and international platforms. She is also a life member of American Physiological Society, National Academy of Medical Sciences, and Indian Physiological Society. So most welcome, Arijita, and I would like to request to deliver your lecture on the topic dysautonomia resonating with a low mood. So Arijita, over to you. Please proceed.
Your time is 20 minutes.
Okay, sir. First of all, I would like to thank the organizing committee, ma'am, everyone for giving me such an opportunity. It's really a proud moment for me to present myself. And since already sir has told, this is my roots today, whatever I am, today it's because of BLD. And when first I saw P.S. Shankar sir in front of my speech in the pamphlet, so I was wondering, I used to take his books in the clinical postings. So it's really a great honor for me. So I'll start with my topic, that is dysautonomia resonating with low mood. Now, there are two entities in my topic. As per the title suggests, dysautonomia and low mood. The first entity, dysautonomia, is the abnormality of the function of the autonomic nervous system. As we all know that autonomic nervous system has got mainly two divisions, sympathetic as well as parasympathetic divisions. Parasympathetic divisions may occasionally contribute, but yes, it is the sympathetic division which produces most striking symptoms of dysautonomia, like postural hypotension or orthostatic hypotension, where the patient usually presents with lightheadedness, fainting, syncope on exertion. Then there are alterations in the sweating because of defective thermoregulation, urinary disturbances like stress incontinence, urgency, frequency, sexual dysfunctions, and also bowel related problems. Now, all these problems can be due to primary dysautonomia, which is mainly of neurodegenerative disorders, or secondary dysautonomia, which is generally of non-neurogenic in nature. Now, second entity is the low mood. As per the DSM 5th edition criteria, low mood in mood disorders usually refers to depression. Provided it is present for at least 2 weeks with 5 or more symptoms, one symptom has to be or primarily low mood or loss of interest or pleasure. Other symptoms can be present like weight loss, weight gain, disturbance in the sleep, fatigue, etc. So we all can see, we are aware because of our surroundings, incidents, and the news that the burden of depression is high and rising globally. And also, it poses an important risk for the cardiovascular diseases like myocardial infarction, hypertension, coronary artery disease. So apart from the lifestyle factors and the socioeconomic factors, it is very important to explore the connecting link between the central neural networks, which regulates the mood and the cardiovascular disorder. So based on various few questions like why still 60% of the major depressive disorder patients they still show little response or no response to the first line treatment of depression, or why there is relapse after the stoppage of treatment, or most significantly why there are sudden cardiac deaths occurring in this type of patients, both in adults as well as elderly population. So we hypothesize that it is not the changes in the brain solely, rather the central autonomic neural network abnormality along with the brain heart interplay dynamics and dysregulated immune system, which could lead to the various events in depression and sequelae in depressions. So pathophysiology of depression is usually multifactorial. So starting from the neural substrates or the neural structures which govern the central autonomic network, that is prefrontal cortex, limbic system. Then we have hypothalamus, which forms the neuroendocrine pathway. That is the hypothalamo-pituitary adrenal axis, which usually gets overactivated because of the lack of feedback inhibition. The neurotransmitters level are usually decreased because of course, not the sympathetic ones, like norepinephrine levels are increased, but like serotonin, dopamine, these neurotransmitters are usually decreased because of the dysregulation in the kynurenine pathway, which is an important major pathway for tryptophan metabolism. And these all finally lead to various pro-inflammatory cytokines in the patients, in the body of the depressive patients, which finally cause the free radicals overload and hence oxidative stress. So if we just see the schematic diagram of the central neural network, autonomic network, and the peripheral network, we can see this is a prefrontal cortex. This is the central autonomic network, which includes amygdala, insular cortex, ventrolateral medulla, nucleus tractus solitarius, which the supramedullary structures are all converging into the NTS, where we also have the cardiac and the respiratory centers directly connected. We can see hypothalamus in a way governing the endocrine axis. Mainly the output or the peripheral efference is through the postganglionic parasympathetic as well as sympathetic fibers. And mainly the parasympathetic fibers reacting to the stress is governed by the nucleus ambiguous, whereas the baroreflex circuit is mainly maintained by nucleus tractus solitarius. We have here the diurnal clock. This is the suprachiasmatic nucleus, and which maintains the circadian rhythm. And we have the hippocampus also over here, which plays an indirect role in memory-related autonomic regulation. For example, contextual fear. The black core areas which are mentioned over here are mainly the centers which are involved in emotional modulation. So besides this, increased hypothalamo-pituitary activity is mainly caused because of the lack of feedback inhibition. And this gives rise to excessive of cortisol, which finally destroys the hippocampal dendrites. So, and we know hippocampus is the main site for consolidation of memory because of the long-term potentiation which occurs over there. So that gets also hampered. The inflammatory theory or the hypothesis is mainly because of the pro-inflammatory cytokines which were found in the patients of the depressed like subjects. And there, as I already told, there is a dysregulation of the kynurenine pathway. So this is a major pathway for the tryptophan metabolism, where there is a shift from the serotonin to the neurotoxic products, which means the metabolism occurs in such a way that the neurotoxic products are formed more and the serotonin is produced less. And finally, since the neurotoxic products are formed, so there will be obviously inflammation and pro-inflammatory cytokines, and that will cause oxidative stress. So based on the two neurobiophysiological theoretical models, the first is Porges polyvagal theory, and the other one is the most important neurovisceral integration model. So various experiments have been done. Porges polyvagal theory says that the autonomic function is mainly related to the vagus nerve, and mainly that is concerned with the affective behavior and the emotional perceptions. So if there is any standard assessment of vagal tone, that could be a potential marker to mirror different types of behavior which we see. And very few studies have been done, and one is of seen in autistic behavior in children. The other is the neurovisual integration model. This is a very important psychophysiological model, which is actually telling the interplay between the central nervous system and the somatic function. And this tells how various sets of areas of brain that could be involved in affective as well as cognitive as well as autonomic regulation, and how they are related to heart rate variability and cognitive performance. So based on this scientific evidence, growing scientific evidence, it is very important to quantify the autonomic dysfunction or autonomic dysautonomia. There are various tests available which are very much available in case of tertiary care centers, and those could also be implemented at primary care level, like cardiovascular autonomic reflex test. This almost every since we are in physiology, everybody will be knowing their Valsalva maneuver, deep breathing test, isometric hand grip, cold pressure test, orthostatic state head up tilt test, heart rate variability, that's a beat to beat variability which is done, and baroreflex sensitivity is the change in the RR interval with per unit change in the blood pressure. That is the spontaneous fluctuations of blood pressure or blood pressure variability. Also, we have the measurement of neurotransmitter levels. That is the noradrenaline spillover test. Now, this is an invasive test to check the norepinephrine level in relation, plasma norepinephrine level in relation to the sympathetic activity. We have QSAT, that is quantitative axon reflex test, and thermoregulatory sweat test. These are usually done to test for the postganglionic sympathetic cholinergic pseudomotor axons. And microneurography is again an invasive test to check. It gives a direct measurement of the muscle as well as skin sympathetic activity, the vasomotor activity, by inducing vasoconstriction modulated by baroreflex. So Mayo Clinic has given very nice two scales based on the symptoms as well as based on the severity. The first one is Compass 31. Now, Compass 31 is a very newly validated scale. Initially, it was autonomic symptom profile, which was established questionnaire, and it used to have 169 questions based on various symptoms, which used to assess 11 domains of autonomic function. Now, this is not only related to cardiac domain. This is, I am talking about pan dysautonomia, like other body systems are also involved. So, but this 169 question is very tiresome to execute at a clinical setting. So, in 2012, it came up with Compass 31, that is composite autonomic symptom scoring. And it usually checks for the 6 domains, that is orthostatic intolerance, vasomotor, gastrointestinal, secretomotor, pupillary, and urinary, which it has its own questions like whenever you stand up, do you feel giddiness? Do you faint? How many times it happens? Whether there are color changes in your body? How many times you have seen? Whether you have colicky pain in abdomen? So these sorts of questions are there. The scoring is done from 0 to 100, and this score is a validated scale, and it is having a good internal validity. The next is that was based on the symptoms. This is composite autonomic severity score, CAS, which is usually based on the cardiovagal, adrenergic, and pseudomotor functions. We based on mainly 4 tests. We do Valsalva maneuver, deep breathing, then head up tilt, and QSAT. So based on this, we generally severity is assessed, whether it's mild autonomic failure or moderate or severe generalized autonomic failure. So this is very interesting topic, and various studies been done. So I will just brush off with this. Heart rate variability nowadays is considered to be a important neurocardiac marker. How much variability is there? to that we assess time domain geometric analysis. What are the rhythms and what are the how much power does on each rhythm is having. For that we go for the spectral analysis based on the fast Fourier transform algorithm, that is frequency domain analysis. And this I will talk the non-linear analysis. It's a bit complex measures. Now, before that, I will give the schematic overview of the ECG signal signaling, how it is done. When the acquisition of the ECG signal is done based on the filter, bandpass filter and a certain frequency, then precondition of the signal is done. We get the R wave because we are actually checking for the RR intervals. So R wave peak is determined, generation of the RR time series, and we get various analysis like linear measures we have, non-linear we have. Linear mainly time domain and frequency, which I had already told. Now, non-linear analysis is very recently developed, very recently introduced, but we don't get much literature based on that because it is very complex to carry out. It involves various machine learning methods. But at the same time, nonlinear analysis or fractal indexes are very important and very significant to assess the vagal alterations because it does not get affected by the fluctuations, and it is very useful for the long-term recordings. And as tonic vagal activity usually correlates with the long range of heartbeat interval alterations, so this analysis is very important. Now, what we have done in IIT, HRV instruments, if we want to set up an autonomic function lab, it will cost like the whole apparatus will cost more than 60 to 70 lakhs. So like it's just a channel subscription. For every channel subscription you have to pay. So whether I want to add pulse wave velocity to it, I have to give extra. Whether I have to add non-invasive blood pressure monitoring, then I have to pay. For there are various channels for that. So nonlinear analysis is you can understand, since various artificial neural networks and machine learning techniques are needed, the cost will reach like up to sky limit. So what we do, we take the ECG recordings, draw ECG recordings from the using Holter monitor, which is very easily available and they are comparatively low cost. And we have collaborated with the biomedical engineering department over here for this nonlinear analysis. For this nonlinear analysis, various, because they are very much used to the neural networks. So various studies till now which have been done in autonomic dysfunction in depressions, they have their own limitations. Like in 2015, the studies they had shown that yes, the depressive patients have got increased sympathetic tone with high LFHF ratio, but it is not correlated with other autonomic domains. And also immune markers were not correlated or not studied. In 2018, gastrointestinal motility was studied. Again, the rest of the domains were not studied. Non-specific inflammatory markers were studied, like interleukin-6 and C-reactive proteins were increased in the depressive patients, but these generally don't, these are non-specific inflammatory markers. These are not specific inflammatory markers related to the immune pathway. So or even orthostatic intolerance symptoms were also seen in a pilot study which we did. We took the patients with major depressive disorder patients and compared with the healthy controls using the Compass 31 questionnaire. Now we are checking the global dysautonomia because 6 domains are usually covered in Compass 31 questionnaire, and we found that the mean score of this Compass 31 was comparatively high compared to the controls, and also these differences persisted in the various domains like vasomotor, mainly vasomotor, orthostatic, and the gastrointestinal domains. And also we have done regression analysis to find out which of the variable is much more important for this increased Compass score. We have correlated with the severity of the depression scales, major depression disorder scales. Now this further, actually this is a pilot study because of the sponsored research project which we are doing. The cases and the controls both will be subjected to ECG signals, and ECG signals here both we will take, that is the linear measures and the non-linear measures, which have not yet done right now. So non-linear measures, mainly we are doing wavelet feature extraction, and this we will be correlating with the compass and the CAS scores, both the symptom score and the severity scores, and we will use the specific inflammatory biomarkers we are using. The one related to the kynurenine pathway, that is the metabolite, that is antranilic acid, and another one is the immune regulator, immune marker, that is specific to the tryptophan kynurenine pathway, that is neopterin. So we are correlating with this. This is still ongoing project, and the future directions of this topic is, first and foremost, we know when by prescribing medications, we don't know how the medications are affecting the autonomic nervous system. In elderly patients, they are also suffering from depressions. Medications are given. Already, the elderly, it's a proven fact, they have deranged autonomic nervous system. So what if the medications also contribute to their derangement? So we don't know that. So that need to be assessed, and neuroautonomic responsiveness to stressors need to be also find out, because that's an indicator, autonomic functions in response to emotional challenges, various emotional challenges or provocative stress test can be used. The most important is heart rate variability feedback. Now, till date, there are very few applications that this is given as an adjunct therapy to the depressive patients. But this is a very important, as per the literature, that it has got a good vagal control of the heart rate. The person is asked to breathe in a particular resonant frequency, and that will augment the respiratory sinus arrhythmia and finally modulate the baroreflex. Finally, it will cause the increased baroreflex gain. So in future, based on this growing scientific evidence, it might result that the physicians will run psychometric test on the cardiac patients, or likewise the psychiatrist may be using Holter monitoring to check for the depression as a neurovascular disease. And also the medications, the treatment modality might change, because not only by focusing mainly the central nervous system as a whole and giving importance to the brain heart interplay dynamics. So this is my team, which we are doing the sponsored projects, and he's the main person who usually deals with the biomedical signaling, Professor Gautam Saha. We have a neurologist and a psychiatrist and a biochemistry person also with us. With this, I would like to conclude my topic. Thank you.
So thank you, Arijita, for your very nice presentation. And I hope we are running a little bit late, so we can. May I take one question?
Only one question, if anyone want to ask, because she is young, too young.
Yeah.
So,
Any question from the audience? Yes.
Thank you for nice presentation. Actually, you
you
mentioned
can
about
come a little closer, otherwise she will not be able to hear.
actually you mentioned about the measurement of neopterin. So, my first thing to know that how ANS actually driving the kynurenine toward this neopterin and quinolinic path, because quinolinic acid is highly good marker for this kind of neurotoxicity. So, why you are excluding quinolinic acid or xanthonic acid and only targeting the neopterin? I think those, including inclusion of the quinolinic acid will be more good marker for this kind of ANS mediated alteration or driving of the kynurenine towards this pathway rather than making it towards the serotonin pathway.
Thank you for your suggestions. Actually, whatever literature we have searched, we have neopterin we are taking because of the immune regulator, and antranilic acid we are taking as a metabolite for the pathway. But yes, quinolinic acid can also be taken. I will take that into account, because we are more to see that how much toxic metabolites are forming in those patients.
and you also can add some kinds of balancing between the IDO1, TDO2. You can get some kinds of idea about how this kind of tryptophan actually getting towards more to the quinolinic acid or neoprene pathway, because IDO1 and TDO2 balancing is very much important for this kind of driving of the chionine towards this pathway.
Okay.
Okay, thank you, Arijita, for your nice presentation. Hope we'll meet again physically in the Physicon
Yes.
next year.
Yes.
Okay.
So thank you, Arijita,
Thank you.
for your wonderful talk. And your citation will be sent by email. Okay. And we are very happy you are here. You are our alumni, and you are here in this occasion. And but physically, we would have been more happy if you were physically present here.
Definitely, I would visit, sir. I will visit.
Along with your husband. Along with your husband. Okay. Thank you.
Bye.
Thank
Now,
you.
thank you. The next speaker, Dr. Benedito. Benedito.
Hello, good afternoon.
Yes, Professor Machado, please come. Yes, nice to see you, Professor Benedito from University of Sao Paulo.
Yes, thank you, Professor Cusal. I am here. Okay,
Yeah,
good. Thank you.
We are very happy. And how is Luciane?
Oh, she's fine. Thank you. Oh, everything is okay.
And Thiago and Dr. Thiago. Thiago.
Oh, yes, Thiago is also doing very well. Oh, yeah.
Convey my
That's right.
wishes to him. Best wishes.
Oh, yes, I will. For sure. I will send your wishes to them. Great.
Thank you. I think that it's a great honor to be with the Professor Benedito Machado, who is from our IUPS Council member and one of the very important person in the IUPS movement, and who conducted the IUPS in Sao Paulo in Brazil at, I think, Rio de Janeiro, Brazil.
That's right. Yeah.
He was the organizing chairman. He's all in all in there. And he's a great physiologist, no need to introduction. I will just introduce here some important person. Our Physiological Society of India current president.
Yes, sir.
Yeah, Professor.
Oh, it's my pleasure to meet you virtually. I hope that the next time I will be.
From University of Calcutta, he is there, and your other professors are there, and now your chairperson of the session will
Okay.
Dr.
Good
Pal.
afternoon.
Good afternoon, sir. Nice to meet you. After 18 years, I am seeing you.
That's right.
I first met you when I was a student there.
Oh, this is nice.
Yeah. So nice.
I think that was my last time, last visit to India, 2014. Then I was there after several visits to India. So thanks again for the invitation. I'm always happy to be together with you in the Physicon.
It's a virtual. It's a virtual, not physically. You didn't come, so it is virtually.
Virtually. Yeah, that's right.
Yes. Okay.
Let me introduce sir, Professor Benedito H. Machado. He is a full professor of the Department of Physiology of the School of Medicine of Ribeirão Preto, University of Sao Paulo, Brazil. His laboratory is fully oriented to studies in the central neural control of autonomic and respiratory functions, with focus on the neuron-astrocyte interaction in the synaptic transmission of the cardiovascular and respiratory reflexes at the brainstem level of rodents previously submitted to hypoxia. Professor Machado trained more than 40 physiologists, published more than 170 papers in international journals, and several book chapters in this field. He is a member of the Brazilian Academy of Sciences. So, heartiest welcome to Professor Machado. And sir, I would like to request to deliver the plenary lecture in this auspicious gathering. Please, sir, over to you.
Yeah.
Okay, thank you very much for the nice introduction.
Yeah, Benedito, your talk will be for 25 minutes. 25 minutes. Yes.
Okay, I will do that after you confirm that my slides is on. You can see my slides?
Yes. Let's see.
Okay, so they are moving, yes?
Yes, it's moving.
Perfect. Okay, I will thank you. I thank again very much for the nice introduction, and I will be on time. So initially, thanks to all the organizers, especially Dr. Bagali and Professor Kuzaldas. And it's, as I said, it's always a great pleasure to be in India with the Indian physiologists. And I have been in India several times, and I hope to be back for visits face-to-face on the next few years. Okay, today I will talk about the sympathetic respiratory coupling and hypertension in rodent models of experimental hypoxia. This is the topics in investigation in my laboratory. And the main question of this talk is, what is the contribution of changes in sympathetic respiratory coupling to hypertension observed in some experimental models of hypoxia? The highlights are strains of rats, sex, male and female, models of hypoxia, physiological condition. I use different approach, preparations, freely moving rodents, and sleep-awake cycle, as well as experiments in mice. So we submit these animals to chronic intermittent hypoxia from fraction of inspired oxygen from 21% to 6% for a few seconds, and then back to normal fraction of oxygen. Or the sustained hypoxia protocol, in which the animals stay 1 day under 10% of oxygen in their chamber. And the control animals is maintained in the fraction of 21%. So let's talk initially to rats Wister submitted to chronic intermittent hypoxia. When submitted these animals to intermittent hypoxia, after several days, they became hypertensive. They present a significant increase in arterial blood pressure. So we use ganglionic blockade. You can see that the fall in pressure, arterial pressure in these animals is greater than in control. So hypertension in chronic intermittent hypoxia rats is due to sympathetic overactivity. So when you use the so-called working heart brainstem preparation, here is the recording of sympathetic nerve activity, and the phrenic nerve, which is the reference for the respiratory, the inspiration, in fact. So when we look to these animals with chronic intermittent hypoxia, to the abdominal nerve, we see that in the late phase of expiration, the animals submitted to intermittent hypoxia, they present an active expiration, which I will refer as late expiration, which correlated very well with a large increase in sympathetic nerve activity, which is not observed in control animals. Therefore, the sympathetic overactivity in CIH rats correlates with active expiration. So this is the title of this talk, the interaction, the coupling in between the sympathetic and respiratory activity. So we study also in awake freely moving rats during the natural sleep cycle. So recording the electromyogram and electrocorticogram, you can identify the phases of the natural sleep cycle: wakefulness, non-REM, and REM sleep in control and CIH, and recording simultaneously the respiratory activity using the plethysmographic chamber. So when you look to this data, we verified that in the wakefulness, all the cardiovascular parameters were significantly increased, as well during non-REM, as well in REM sleep phase. So therefore, it does not matter if the animal is awake or in REM or no REM sleep phase, they present a significant increase in the arterial pressure and supposedly also in sympathetic nerve activity. So when we record this, the abdominal, the electromyogram, the diaphragm activity, muscle activity, and the neck electromyogram, and electrocorticogram, we verify that the active expiration is observed only during the wakefulness, but not during the two phases of the sleep cycle, no REM and REM. So this active expiration in freely moving animals in natural sleep cycle is observed only when they are awake. So the incidence of this active expiration in control and this rat submit to intermittent hypoxia, we verified that the incidence of this active expiration is significantly higher in CIH than in control, but this observed only during the wakefulness. So in summary, for these male Worcester rats submitted to chronic intermittent hypoxia, they present changes in the late expiratory phase, which correlates with increase in sympathetic nerve activity. They are also present hypertension, this active expiration in wakefulness, but not during the sleep phase, and a higher incidence of active expiration during the wakefulness. So let's now look for the comparison of male and female submitted to this chronic intermittent hypoxia. So in female, we also observe a significant increase in mean arterial pressure after these animals were submitted to chronic intermittent hypoxia. So female, like males, also are responding to this challenge, hypoxic challenge, and they increase their arterial pressure. So when you look in the working heart brain stem preparation, we verify that the female rats presents their increase in the sympathetic nerve activity during the inspiration. So this is something different in comparison with the males. So if you look here, as I mentioned in the previous slides, the increase in sympathetic activity in female rats is observed during the inspiration, while in male, as I mentioned before, the increase in sympathetic activity is observed in the late phase of the expiration. So although females also present increase in sympathetic activity and also in arterial pressure, these changes in correlation with the respiration is different. Female in inspiration, while male during the final phase of the expiration. So in summary, for these female rats, although female also presents hypertension in response to chronic intermittent hypoxia, the increase in sympathetic nerve activity is observed during inspiration, but not in the late expiratory phase. So now let's look to another model of hypoxia, this so-called sustained hypoxia, in which the animals are maintained for 24 hours with 10% of oxygen in the inspired air. These animals submitted to sustained hypoxia also present a significant increase in mean arterial pressure. So it means that they became hypertensive. And when you look to the correlation in between the sympathetic and the late expiratory phase, it is also present, indicating a coupling in between this change in the expiration and the increase in sympathetic nerve activity, which may explain why these animals are hypertensive. In summary, for these male Worcester rats submitted to sustained hypoxia, we observe that male Worcester rats submit to sustained hypoxia also develops hypertension, and the change in the late expiration correlates with an increase in sympathetic nerve activity. So let's look to another strain of rats, the strain named Hanover, and submitted these animals to sustained hypoxia. In this case, these animals present no change in mean arterial pressure or any other of the cardiovascular parameters like systolic, diastolic pressure, or even in the heart rates. So when you look in these Hanover rats for these recordings and the correlation in between the nerve, abdominal nerve, and thoracic sympathetic nerve activity, we observe that the Worcester Hanover rats, they present no increase in the abdominal late E, difference of this other strain of Worcester, in which during the late expiration, they presented this large increase, the respiration became active, and an increase in sympathetic activity. So this is indication. So in addition, the sympathetic activity and the incidence of the sympathetic activity in the late in the in situ preparation of these Hanover rats was relatively low compared with the Worcester, another strain of rats. So the baseline sympathetic activity in these animals was not increased. So no change in baseline sympathetic and just a mild increase in the incidence of the late active expiration. So in summary, for these Worcester Hanover rats submitted to sustained hypoxia, we observed no change in the baseline mean arterial pressure in response to sustained hypoxia, which correlates with a low incidence of the late active expiration and no change in the sympathetic nerve activity. So now let's move to a third strain of rats that named Sprague-Dawley and submitted these animals to sustained hypoxia in the same protocol, 10% of oxygen for 24 hours. And we observed that these strains of rats, they present increase in arterial blood pressure, a significant increase in mean arterial pressure. And also they presented the correlation of the increase in the late expiration, active expiration, correlated very well with a large increase in the sympathetic nerve activity. So this strain of rats, they increase the baseline sympathetic activity, and the incidence of the late active expiration is 100%. And a large increase, a significant increase in sympathetic nerve activity, which may explain why these animals became hypertensive. So in summary, for this strain of Sprague-Dawley rats submitted to sustained hypoxia, we observed that they became hypertensive, and this hypertension correlates with the high incidence of late active expiration and increase in the baseline sympathetic nerve activity. So now let's move to another species of rodents, this very used these days in most laboratories around the world, mice, and specifically the strain C57 black. These animals, these mice were submitted to sustained hypoxia to the same protocol used with rats. And we verified that these animals present absolutely no change in any of their cardiovascular parameters, neither in mean arterial pressure, absolutely no significant change in cardiovascular in arterial blood pressure. So when we record the sympathetic and abdominal nerve activity in mice submitted to sustained hypoxia, we observe that these animals, although they present the active late expiration, it does not correlate with any change in the sympathetic activity. So sustained hypoxia in mice increase the incidence of the late expiration, but no increase in the sympathetic nerve activity. Sorry. So the incidence of this late E in, sorry. So the incidence of late E in mice was very high, but in fact, no change in the sympathetic nerve activity. So the increased incidence of late E, the active expiration, in fact, correlates with a reduction in the sympathetic nerve activity. This is the increase in the incidence, and this is the reduction in the sympathetic nerve activity. So in summary, for these mice, although mice present a high incidence of the late active expiration in response to sustained hypoxia, they also present reduction in sympathetic nerve activity during this late expiration, and no change in baseline mean arterial pressure. It means no hypertension. So in conclusion, and I will be ahead of time and we'll have a time for discussions, I summarize all these data with these comments. So simultaneous increase in abdominal late E and sympathetic nerve activity are correlated with hypertension in male rats, but this is dependent of the strain and the physiological condition of the recordings, in situ preparation, awake, and the specific phase of the natural sleep cycle. This is important for physiologists. We need to look for a phenomena in a different ways, in different approach, to verify if we can confirm the observation made in just one preparation. Second, although female rats submit to chronic intermittent hypoxia also develops hypertension, the change in the respiratory pattern correlate with the increase in sympathetic nerve activity is different from male, as I showed, inspiration versus late active expiration. So female rats presents a different neural control of the respiratory pattern. And this is something that we need to look carefully, because females and males, they are not uh, using the same neural circuits to regulate respiration, especially under challenge conditions. Third, mice submitted to sustained hypoxia, in spite of the increase in the late active expiration, presents a reduction in the sympathetic nerve activity and no hypertension. So mice, we are using these days mice, transgenic animals, for several other reasons. And these animals, they do not behave like rats when they are submitted to hypoxia. And this is important to understand, from that natural environments are quite different of those that the rats came from. So in the laboratory, although they are rodents, in this case, they are quite different. Fourth, it is still difficult to determine in male rats if the respiratory pattern, the late active expiration, are affecting the long-term baseline sympathetic nerve activity and contributing to neurogenic hypertension. And this is due to the fact that the incidence in awake, freely moving rats of this active expiration was of approximately 11%. Oh, sorry. The correlation between the incidence of late expiration, active expiration, and the increased sympathetic nerve activity in some experimental models, male rats, and the change in the respiratory pattern and increase in sympathetic nerve activity in female rats are consistent with the concept that change in the respiratory pattern may contribute to neurogenic hypertension. So this is important in our laboratory, because now we can identify the strains of rats and the sex of the rats and how they respond to challenges such as chronic intermittent hypoxia or sustained hypoxia. And although they present increasing sympathetic, it correlates with a different phase of the respiratory cycle. So I wish to thank all the collaborators in these studies for several years in my laboratory, several graduate students, postdocs, and some faculty that are collaborate with us from different universities here in Brazil, as well Professor Julian Payton from the University of Auckland in New Zealand. Just to finish, I just wish to let you know that the content of this talk was published recently in the Advanced Experimental Medical Biology, exactly the content of this talk that I presented to you. And those that wish to visit the website of our laboratory, as well my email in case of any question and comment that you wish to send to me. So thank you very much for your attention. If you have time, I will be more than happy to ask you to answer your questions. Thank you.
Thank you, Benedetto. Thank you very much for your wonderful deliberation. So over to the chairperson, Dr. Shri Pal.
So I am very much excited to hear from you, sir, and you have very elaborately explained that how the actually different types of species or strains can react to two different types of the hypoxia. That is, one is the chronic intermittent hypoxia and another is the sustained hypoxia, and how their respiratory changes are there. Inspiration and expiration can change, and what are the consequences in terms of the autonomic sympathetic activation in them. So I have I want to know that is there any genetic predisposition behind that species variation in that kind of differential responses to hypoxia, or some
Yes,
other factors are there?
okay, no, you are right. So, no, thank you very much for your comments and your question. That's right. So probably this is not only the genetic backgrounds of these different strains of rats, or especially the mice. Because the mouse, for example, they live in a very different environment where they are naturally adapted to low oxygen in their environments, while the rats live in a different environment where oxygen is the pressure of oxygen in the air is much higher. So when you are in the laboratory trying to reproduce the nature, we put all these rodents together. I must be honest and tell you that for several years, we are just working with one strain of rats and male rats. And that was true, all that data for that specific strain of rats. But it's not true for other strains of rats that may be genetically different from that Worcester, as Hanover. As well, the mice, although they are rodents, their response is completely different. So this is something that now we are looking carefully. As well, the sex of the animals, which make a large difference if you compare males and females. This is, look, our approach is just to coupling autonomic and respiratory response to hypoxic challenges. But of course, this is true for any other physiological parameters. We must be very careful in our experiments in order to, if you are thinking about translational medicine from laboratories to human beings, before of this translation, we must check if the strains of rats or mice, or even the strains of mice, now we are exploring different strains of mice, and they are quite different from each other. So before we translate to human beings, we must translate from one strain to the other strains among rats, among mice, and verify if these finds are really reproducible in different strains. Otherwise, it will be very restrictive just for one strain of rats. And it's very important to highlight that most laboratories around the world, including my own laboratory, in the last few years, we put together data, comparing data of rats with mice, and assuming that data from mice are similar to rats. We were wrong. It's not acceptable after we verified that they are so different. I don't know if I answered your question, but this is my...
Okay.
Thank you, Professor Benedito, and once again, thanks on behalf of the organizing committee and also from the PSI, Physiological Society of India, in which you are closely associated since, I think, nearly 2 decades. You are there, and you are one of the highest award recipient, SC Mahalavish Memorial Oration Award recipient. So we are very honored to be here. You are here with us, and in future we want to see you physically in BLDE University. Thank you.
For sure, I will try my best to be personally with you in the next meeting. Let's try that, Professor Gonzalo. I will try. Thank you very much for the invitation. It's really a pleasure to be with you. Thank you.
And come with the Luciane.
Yes, for sure. We will love, as you know, we love India. I have been in India 6-7 times.
In Vijayapura also visited one time.
That's right. I was in Vijayapura. Now it's time to visit you in Vijayapura. Vijayapura. Yeah, that's right.
In 2006, I think you have visited here. Again, you will be visiting.
That's true. Yes, we were together in Vijayapura. That's true.
Thank you. And your citation will be sent by email. Okay.
Okay. Thank you very much. I really appreciate the invitation. It was a pleasure to talk with you. In case that you have any questions, please send me by email or...
All queries will be sent to you by email.
Thank you very much. Thank you. I appreciate.
Thank you, sir.
Now, I think Professor Trevor. Hello, Trevor. How are you?
Greetings, colleagues.
Hey, nice to see you.
Nice to see you. Greetings from Africa and South Africa in particular.
Yes. How is Cape Town? How is Cape Town now?
Well, Cape Town apparently is a bit cold, but I'm in Johannesburg, which is about 1,000 kilometers from Cape Town.
So thank you. And now I think that the chairperson, Dr. Rekha Udgiri Madam, so she is Dr. Rekha Udgiri, the professor of community medicine, public health, and an expert in medical education of our university, and she will introduce you, and she will do the formal needful. Over to Dr. Rekha Udgiri.
Hello sir, good evening. So here is a Professor Chivara Natkoda. He is a professor of medical physiology at the University of Pretoria in South Africa, where he is associate professor in the Department of Physiology and School of Medicine. He is a BSc Honor, MSc Medicine in Physiology, and a doctoral degree in medical physiology, graduates from Wits University. He also holds a postgraduate diploma in health sciences education and an MSc in health science education from Wits University. His preclinical medicine research focuses on neonatal programming and the development of origin of health and metabolic diseases. He makes use of neonatal and adult animal models to investigate the potential therapeutic efficacy of alternative and complementary medicines administered during the critical window of developmental plasticity against a diet-induced metabolic dysfunction. And Professor Nakodia possesses a profounder passion for the field of physiology education. His primary area of expertise revolves around the exploration of the threshold concepts within his disciplines and their impact on students' epistemic access to the subject matter. And Professor Provera is a member of Education Committee, IUPS. So here I present the Professor Provera. Over to you,
Thank
sir.
you very much. Thank you very much for the kind introduction. I hope you can clearly hear me and that my slides are okay. Are the slides moving? Just to confirm?
Yeah, it's working.
Yes.
Great. All right.
Yes, IPS.
All right. Okay, thank you very much. I want to take this opportunity to extend my gratitude to the organizers of this prestigious conference. It's an honor to be here to talk about some of the work that we are doing or that I'm doing. This is actually secondary to what I spend most of my time doing. Just like Professor Machado in Brazil, I also spend a lot of time with animals in the lab, just exploring metabolism and developing drugs for the management of non-communicable diseases. But as I grew older in academia, I then developed a secondary passion in physiology education, because as I was teaching the medical students and science students, it became very apparent to me that there's quite a number of things that are missing. We spend so much time researching on hardcore physiology, but we don't really spend a lot of time researching how we can improve the learning experience of our students. So that then got me to this point now, where I then went on to study for a postgraduate diploma in health science education and a master's in health science education. And one of the things that really got me interested was neurophysiology, being one of the areas that I'm involved in teaching. I noticed that over the 20 years that I've been teaching medical students, there's been a couple of students that seem to struggle, with understanding neurophysiology. But maybe just as a way of introduction, we all know as medical educators that physiology is key in the training of medical students. It provides an understanding of the human body to the students, among all these other advantages that it confers to our students. So we can all agree that the teaching of physiology is very, very important in the training of our medical students. So having said that, I'm not sure what you use in your university, but in most South African universities, we use what we call a systematic approach in the teaching of physiology. So what we do is we start off with, basic introductory concepts and aspects of physiology, and then we build onto that as we go on to a higher level and higher order systems, which increase in terms of the complexity. And for that, we make use of a variety of methods, some of which are general didactic lectures. We also use flipped classrooms, and with the advent of educational technologies, we are also now incorporating education teaching methods that are based on the use of technology. So that makes teaching a bit exciting. I mean, you all know that with COVID, we couldn't see the students face to face. So we had to become very, very innovative in how we actually still teach our students under those difficult circumstances. All right. Now, coming back to neurophysiology, I mean, it is also quite important because of its integrative nature and regulatory nature, just like the endocrine system. It is very paramount. It is of paramount importance for the students to really have a clear and a deep understanding and grasp of neurophysiology. Not only do they get to understand brain function, but they also get to receive knowledge that will help them in clinical diagnosis, as well as research and innovation for those that may want to continue and pursue with research. And above all, understanding of neurophysiology helps them to understand how the different systems work together as they maintain homeostasis. So we can all agree now that neurophysiology is very important just by virtue of its integrative nature and regulatory nature. Now, so as I said earlier, what I've seen is that most of these students, as they learn or as we teach them neurophysiology, they seem to struggle to understand certain concepts, right? While others do understand it so easily, we find that the majority face what we call cognitive challenges in terms of understanding neurophysiology. So that to me led me to think that there may be some factors that constrain the learning of neurophysiology, in as much as there are factors also that enhance the epistemic axis of neurophysiology knowledge. Now, so what then are the implications of the students' failure to understand neurophysiology? Obviously, there is an incomplete integration of physiology knowledge of other systems. Now, given that neurophysiology is a control system that works together with other systems, if they fail to understand neurophysiology, there's a high chance and probability that they may also struggle to understand how the other systems work together in maintaining homeostasis. And not only that, what we also see is that there's fragile knowledge building. So there will be gaps in the knowledge of these students if they don't really comprehend and understand neurophysiology. There's also inadequate application of neurophysiology knowledge, especially when they go on to the clinical years, where they're supposed now to apply some of these concepts that they will have learned in neurophysiology. So if they can't understand the basic neurophysiology knowledge, then in terms of the clinical application, it becomes a challenge for them to understand in their clinical years. Now, then that led me to think of some of these questions that needed to be addressed. So one of them being that are the factors that exist which enable the epistemic axis and enhance the understanding of neurophysiology, seeing that some students don't really struggle with understanding neurophysiology? Or are there factors that constrain the epistemic axis, therefore acting as a barrier to the learning of neurophysiology? So these are some of the big questions that I started asking, and I wanted answers to, because as I said, it is very key and important for these students to have a clear understanding of your neurophysiology. So identifying the perceptions of students on these factors that constrain or enhance or enable the epistemic axis of neurophysiology are very important, because it will allow us to support the students in their learning, okay? The learning of experience of the students is enhanced, especially if we are providing effective support to them through the use of effective teaching strategies as well as the assessment criteria, right? And also, this is important because as we develop our curriculum, we all know that, there's a lot of dynamism in terms of the curriculum, physiology curriculum. So if we can identify these factors that especially constrain understanding of neurophysiology, it helps us as educators to develop a curriculum that is well crafted for our students, right? And obviously our assessment criteria will speak to our teaching strategies. So this is all important. So now what then we decided to do is to actually make use of a qualitative research design to answer this question. What did we do? We obviously had to seek ethical clearance because this was conducted at two universities, the University of Wits and the University of Johannesburg in Johannesburg. And obviously relevant permissions were received, and then we embarked on this study. So as you might all be aware, there's different ways of looking at perceptions and viewpoints of your subjects, most of which usually depend on the use of theoretical frameworks. But we didn't go for a theoretical framework per se, but we went with a simple qualitative descriptive study. Obviously, if some of you are interested in this kind of studies, we can collaborate and then make it bigger and possibly then employ theoretical frameworks. But the idea of using these qualitative descriptive studies because of those advantages that are listed in the slide there. Obviously, the focus on the description, which then provides an in-depth and accurate, comprehensive understanding of the phenomenon under investigation. You don't necessarily need a theoretical framework for that. And you also don't require a large sample. You can actually get a small purposeful sample that can help you answer your questions. You can also make use of these open-ended questions. And above all, you also get qualitative data, which can easily be analyzed using the relevant management, qualitative data management tools. And most importantly, the practical applicability of the data that you get using a qualitative descriptive study is one of the main reasons also that we went for a simple qualitative descriptive study. Informed consent obviously was received, and we made use of the appropriate population, student population, which was medical students, and we used purposeful sampling technique, whose advantages are obviously its efficient, targeted selection, its representative nature, the expert knowledge, diversity, as well as the research focus. So the tool that we used to collect our data was basically a simple interview, right? Which was conducted face to face by the participants. So myself and one of my students had to perform these interviews. They were recorded and obviously transcribed. And these are some of the questions that we're asking. So the main question was, in relation to physiology topics that you have covered in the terms or the blocks, how did you find neurophysiology? Then obviously we had prompt questions. These are some of them, examples of them. We had more questions that we asked to prompt them to give us the appropriate responses that would then enable us to answer our research question fully. All right. So after transcribing the data, all right, we made use of a very nice tool that I love so much. It's called MaxQDA. Before this kind of research, I'm quite used to, doing quantitative research where we use our graph-based prism and all. So this was all new to me, and it was quite exciting to actually get to use a different kind of tool, looking at different kind of data. Okay, so MaxQDA, and then we went on to code the interview scripts and used an approach that was proposed by Clark and Brown in 2014. It's called an inductive thematic analysis, where you actually follow a stepwise sort of approach in analyzing the data. So you start off with familiarization of the data, then you generate the codes, and then you search for themes, then review those themes, define them before you then put them out together. Okay. Now, in terms of our findings, so this may sound obvious, man. We always say it, but then there's no empirical evidence, there's no evidence to support that. But what we found in our study was that, among other factors, the three main ones that came up, right, were the fact that the prior knowledge that they learned during their possibly high school, right, was quite important in helping them to understand neurophysiology, the availability of learning resources, as well as the practical sessions. Just to give you a bit of more information, with the prior learning of biological concepts in high school, what we found that if you look at the constructivism, which speaks to how students build, more knowledge onto the underlying knowledge, we found that the prior knowledge of the certain biological concepts that they learned in high school was quite key in their understanding of neurophysiology. And this was actually supported by some of the studies that I put there. Brown and Cooking in 2000 also reported something similar, that when students have a solid foundation in life science knowledge or biological sciences in the high school or prior years before they get to university, it helps them to understand some of these concepts. So we found that, we confirmed that, and our findings corroborates those findings. And then the availability of resources was also key in their understanding of neurophysiology concepts. In our university, we make use of a learning management system called Blackboard. And on that platform, we give them a variety of resources, from journal articles, our notes, and reference textbooks, and all that added to their ability to understand, the neurophysiology. And practical lab sessions as well for some of the sections or areas in neurophysiology. We actually get them to do some practical sessions. I'm sure you all do. And what we confirmed, which has always been almost like said without empirical evidence, is that these laboratory sessions, especially the neurophysiology lab sessions, they were quite important in reinforcing the theoretical knowledge of these, neurophysiology neurophysiology knowledge. So this was quite important, because then it means that with that kind of understanding and knowledge, we can then develop our curriculum and incorporate teaching strategies that will help our students to understand neurophysiology, especially, building onto prior knowledge, availing them with resources, and getting them to do some of these lab sessions. Okay. And then we also identified factors that constrained the learning of neurophysiology and also acted as a barrier to the learning of neurophysiology. One of which was, surprisingly, the amount of work that they did, the language and terminology, the prerequisite knowledge of physical sciences such as chemistry and physics, and the existence of troublesome knowledge and potential threshold concepts. Okay. So the amount of work apparently was quite a lot for them, according to their perceptions, simply because with a lot of work, you tend to get what we call cognitive overload, which causes defective and impaired knowledge building. Terminology was also quite important, because as you all know, when we teach neurophysiology, there's special terms that we use. And for some students, they found that to be quite difficult and a challenge for them to really understand some of these concepts. And then some students who did not have a thorough understanding of physics and chemistry, for instance, they also had challenges in understanding and applying neurophysiology. Now, what was very nice and interesting to me was the existence of threshold concepts. Now, what are threshold concepts? Now, threshold concepts are basically transformative ideas or concepts that are essential for students to grasp in order for them to get a deeper understanding of whatever they're studying, right? So these threshold concepts usually are troublesome in nature, meaning to say that they are initially difficult to comprehend at the beginning, but once mastered, the students will progress to understand more. So what we found was that the generation of action potentials and their propagation was actually a threshold concept, because students were struggling to understand, the concept of, how ions move across the plasma membrane, the resting membrane potential and all that, and how you actually generate action potential and propagate it along a neuron. So for us, we identified that as a threshold concept, because without that understanding, it will be very difficult for you to understand how neurons communicate and how the nervous system is involved in homeostasis. So, just in conclusion, we identified the students' perceptions on the potential barriers of the learning of neurophysiology, right? And this is important because it helps us to support them, especially if they're struggling with these factors that constrain the learning of neurophysiology. This is also, this research also opportunity for us as lecturers to develop our curriculum and our teaching methods, as well as our assessment criteria, in such a way that the learning experience of our students, especially the learning of neurophysiology, is enhanced. So it is important for us to then build on this knowledge and develop interventions that will address the identified constraining factors, so that we facilitate the learning of neurophysiology at our learning institutions. I want to acknowledge the role of some of these colleagues in this project. And some of the people that I look up to, Professor D. Silverthorne and Professor Robert Carroll, and their role in my developing this excitement of physiology education. I'm looking forward to possibly collaborating with some of you if you're interested in this kind of work, where we investigate threshold concepts, not only in neurophysiology, but in other areas of physiology. Thank you very much. Dhanavat.
Thank you, Trevor. It is an excellent talk, very brief, precise. You have maintained the timings. That is wonderful. And thank you from you, and convey our best wishes to in all the South African ourselves from the India. Love and best wishes to South Africa from India. Thank you, Trevor. Over to Dr. Rekha Woodgiri, the chairperson.
Thank you very much.
Hello, sir. It's a nice presentation. Just I have two queries for you. The one is, you said that there are different teaching learning method has been adopted for this neurophysiology. So among the students, when you are asked the which method they prefer for that?
Okay, so you will agree.
You have made so anything they commented on the teaching learning method which found them easy to understand the neurophysiology, anything like that?
Thank you very much for the question. So indeed, they alluded to some of the methods that we use in our teaching. Like for instance, I use gamification. So the use of games, like, I don't know if you know 30 seconds, it's a game that is ordinarily used for entertainment, but I've adapted that into our teaching. And they alluded that it was quite helpful in the understanding of these neurophysiology concepts. I've got a friend of mine who is a computer wizard. He makes use of these animations and graphics, and he helps me now to develop these, to animate some of the processes that are happening in the cells during the propagation and the generation and propagation of action potentials. And they, our students are very visual nowadays. They love technology, so those things appeal to the learning. And they alluded to that as one of the things that they liked. And the last one that they also seemed to like so much was the flipped classroom, especially when we give them material to do before they come for lectures, and they just focus on solving problems and clinical scenarios and cases in class. They seemed also to enjoy that a lot. So yeah, we will continue to use such going forward. But I'll be happy to hear also what your students like as well, so that we can have a unified approach in the teaching of physiology.
Any assessment has been done for the comparison of different the system with the neurophysiology? Any assessment?
So, sorry, Prof, you broke off a bit.
Assessment.
You broke off a bit.
Assessment, yeah. Is conducted to compare with a different system with the neurophysiology among them students. 38 is the students.
You mean the assessment?
Yeah.
The assessment criteria that you use and how they take it as students, right?
Any comparison is made with the different system with compared to neurophysiology?
In terms of assessment, I'm not sure if I get your question right, but in terms of assessment, I think we simply use a variety of questions. And nowadays we have migrated to online assessments, where we use computer-based tests and incorporate all kinds of questions. I'm not sure if I got you broke off a bit there, but in terms of, you mean comparing neurophysiology and other systems?
Yeah, other system.
Oh, okay, yeah. So the same manner that they've used the physiology knowledge, I suppose it's the nature of the knowledge, of physiology. They alluded to the fact that the nature of the physiology knowledge and how it's taught and the terminology that is used, I think makes neurophysiology a bit different from the other systems as well. I suppose that also speaks to the assessment as well. Although we do use almost a similar approach in terms of the assessment and the type of questions that are assessed, but what came out very clearly in our study is how they viewed neurophysiology compared to other systems in terms of the nature of the knowledge.
Okay, thank you.
Thank you very much.
Thank you.
Thank you, Dr. Trevor. Thank you very much.
Thank you very much, Dhanavat.
Yeah, we expect
I
to
hope
see.
to visit you sometime in future. And I also hope that South Africa plays India in the finals of the Cricket World Cup.
Yes, yes, you are very much had a collaboration. Thank you very much, Dr. Tabor. And I now request the next speaker, the renowned neurosurgeon or neurosurgeon from Mexico City, Jose Antonio Carmona. Professor Jose, Dr. Kushal here. Kushal here.
Yes, thank you for this opportunity for
Yes,
me.
nice to
This
see
is
you.
my this is my first opportunity to introduce my talks in a physiology lab like you have in your country. It's nice to see Dr. Professor Kusal. I saw you some years ago in Bolivia. It was really
La Paz we have seen.
yes. It was really grateful for me to see you. It was a nice opportunity to give you for me. This is a special.
Remember, you actually owned my wheelchair on the ship when Gustavo was taking us to the ship.
Yes.
Remember, and thank you for that, for your hospitality, the great lake of Titicaca. Thank you. And now over to Chairperson Shumangala, Doctor.
And both.
Yes, okay. So I try to introduce.
Just introduce the chairpersons. I request Dr. Shumangala to introduce the chairpersons.
Good evening, sir. Myself,
Thank
Dr. Sumangala Patil, organizing chairman of this conference and professor of physiology. And this is Dr. Renuka. She is a professor of anesthesiology, head of the department of anesthesia.
You're
okay, nice to see. Yes, it's quite important because this is really important. This is really important for me. I know a critical care physician. I am not a physiologist. I studied some years in Netherlands, Rotterdam University.
Yes, sir.
So I went to Rotterdam.
Yes, sir. I'll just read out your short CV before you start your presentation,
Yes.
sir. Professor Jose Antonio Carmona Suzao, MD, is a renowned neurosurgery professor, neurocortical care physician, and diplomat at the National Autonomous University of Mexico. Currently, he is a leading neocortical surgeon and neurophysiologist of entire Latin America. Interestingly, he is also professor of critical care medicine for biomedical engineering and informatics at Technological Institute of Laxtapulso in Mexico. Dr. Jose is having several publications and research grants in his credit. He has developed several experimental models of multimodality neocortical monitoring systems. So here I present Professor Jose Antonio. Over to you, sir. You can start.
Thank you for this opportunity, and again, thank you again. So I try to share my slides, but you can see
25 minutes. Your talk 25 minutes and 5 minutes interaction.
Yes, thank you.
Thank you. Over to you. Over to Professor George.
As you can see, the title of the lecture is Brain Tissue Oxygen Monitoring, a leap from animal practice to neurocritical intensive care unit. So I declare no conflict of interest for this academic presentation and also for neurological multimodality monitoring usage, since that it's a practical technical lecture, so we are using some medical devices. It's important to declare this one. Probably you know this guy, I don't know, he was one of the first teachers around the world. He was noted, but the most important physiologists around the world. In 1954, Leland Clark Jr. used a shiny platinum cathode covered with a layer of cellophane. He found it was to be suitable for direct measurement of the tension oxygen in whole body or bipolar radiographic procedures. The cellophane covering prevents the undesirable effects of red cells, which would otherwise interfere with oxygen tension measurement. The cellophane also abolishes the sliding effect. A tiny cutoff of this 2 millimeters diameter and 8 millimeters for long measurement mounted on the catheter can be passed into the major blood vessels for continuous recording of oxygen tension. Those cathodes are easy calibrated and they are stable, impeccable, and sensitive. The catheter was able to measure the tissue oxygen content of the mixture of a venous and arterial blood. The first device was analogic, like the monitor you can see in this slide. Here you can also see the insertion tools for the skull and the calibration card. Has the parameters of barometric, pressure, oxygen content, and of the ambient, humidity, and other important variables for adequate humidity and other contents for adequate calibration and measurement. The initial test was replicable in animals by confronting experiments to demonstrate the effect of secondary injury factors. In this slide, you can see a cat with several catheters. We can count 5 devices and 1 catheter with 2 pumps. This experiment induced a slow and progressive damage in the brain. The initial test, for example, you can see in this dog, the blue oxygen catheter. The letters that you can read is, say, PTO2 and ICP Camino catheter for the ICP monitoring. And on the other side, the dog, there is also an ICP catheter with the agent of the damage. The effects of hypotension, my right side, hypocapnia, hypopnea, hypercapnia, and hypoxia, and other multiple factors of secondary injury damage can affect the brain. In this slide, you can observe the time, the x-axis, and the vertical axis has the cerebral pressure perfusion and 2 oxygen tensions, the parenchymal oxygen pressure, and the intraventricular oxygen pressure. Obviously, the intraventricular oxygen was really high, since the oxygen in the cerebrospinal fluid is a reflex of the ultrafiltrate of plasma, which is different from the parenchymal approach. This last approach was the right one for the human use. The measurements were reliable for reperfusion research. The relations between brain and rectal temperature, mean tissue oxygen, and ventricular fluid oxygen tensions after ICP increase of controlled mean arterial pressure, which demonstrate a reliable measurements and in animal experimental areas. Sorry. The areas of brain tissue captured by the catheter were studied. Initially, because of the optic technology, it captured only an area of 2 millimeters square. A few years later, the area increased to 14 millimeters square, and finally, with more refinements, it now can capture in areas of brain 23 millimeters square. The heterogeneity of the brain tissue sample was established. Since the oxygen values can differ with a 1 millimeter of difference, that's only 1 millimeter of measure from one area to another, when the tissues is suggested 100% oxygen. The oxygen measured by light pulse monitor is the mean of all the values, as you can see in the line, the average line. So we have a lot of samples of tissue oxygen, a lot of these different values, only in very special area. So after some time, we decided to go to the human research. And again, we tested the oxygen catheter in the cerebrospinal fluid and in the parenchymal brain, in the surgical room. As you can see, the response with dopamine start in the red light, and you can see also the response with 100% VO2 in the oxygen. Later, the measurements were carried out to establish the normal good thresholds of the Gord's values. So after this time, there were so many research centers. A lot of centers around the world started to establish what about the normal values. So as you can see, the normal values in the yellow were between 20 to 40s. With those thresholds, the tool was brought to the patients with traumatic brain injuries and other pathologies. We saw in our publications to correlate the brain PCO2 less than 10 millimeters of mercury during 30 minutes with patient characteristics. We cannot observe any one correlations with the age, Glasgow Coma Scale, pupils, multi-trauma, ICP, CT scan variables, the shift, cisterns, the operation of the cisterns was really an interesting result for us. And also the amount of cerebral hemorrhage and CT classification, we don't observe any one. But you can see here the pupils, the response of the pupils, the lateral positive, this one number 47 patients, pupils unilateral positive and negative, and pupils lateral negative with lower values. And only in the initial 24 hours, we can see some special description. And again, new questions. Which systemic factors influence the outcome values? What are the most important? Which systemic factors influence outcome values the most? What about the placement of the insertion? The penumbra area or in the healthy brain area? Which systemic values influence your results in the treatment? A lot of medical question for us. It was really difficult to get some real information about the cerebral fluid, blood pressure, intracranial pressure, arterial PO2, pH, brain temperature, hemoglobin, P50, fluency, hematocrit. So the body is really complex. Therefore, we must to define the outcome, the real indicator for of value, and also the risk of death with low PTO2 values. You can see in the x-axis the total duration of brain hypoxia and the risk of death with lower PTO2 in relation with PTO2 less than 5, between 5 to 10, and 10 to 15. So we are going again to more results. You can see in slide the information about the death and alive. Only in the initial 24 hours was a better results. And again, we had a lot standard deviation. But if we study patient by patients, you can see a nice correlation between the hypoxia events, PTO2, jugular venous saturation, and pulse oximeter saturation. What about the questions? And again, but the next step was to correlate the treatment with the improvement of the patients, such a finding of optimal cerebral pressure perfusion to improve oxygen. They want to look the efficacy of vasopressors to increase brain tissue oxygen and jugular saturations. A lot of studies was developed around the world. So they want to see the difference between this first step and the second step. But it was not easy for several reasons. For example, only 1 or 2 millimeters of mercury of increased oxygen tension are enough to improve the supply in the mitochondria, and this will translate into better oxygen consumption. However, heterogeneity, types of lesion, and even genetic patterns may affect the results. Besides of this, people from USA and other countries developed this study, the BOOST2. Besides the results in TBI trial, with a small number of patients, they identified that the prognosis was partially improved and there was lower tissue hypoxia with both monitors, ICP and PTO2 monitors were used. Then, when only ICP was used, also the difference in the reference variables of prognosis, such as extended coma Glasgow scale or DRS scale. So, with these exciting results, the panorama of the better treatment for breast outcome was more complex. Why? It was needed to treat the patients according to the real parameters of the brain. We found 4 different ways to treat the patients. For example, if you have an ICP below to 22 and PBO2 greater than 20, no intervention needed. But if you have an ICP more than 22 and PTO2, so it was complex, 4 different treatments for any one patient in the ICU. When we have a patient in the ICU who needs to apply different treatments for the same pathology, but the pathology is completely different, one patient for another one. For example, if you see here, slide with a decompressive surgery in a child with 15 years old male with severe head injury and malignant brain edema. This patient, we say it's a malignant edema because he was talking and after went to die. What is possible? So it will start the ICP monitoring and brain tissue monitoring, PTO2, and we can stop the treatment and we can see the ICP goes down and the brain tissue oxygen goes really up and increases. The catecholamines reduction. So in which square of the last slide you put the patient. So it's not simple to treat a head trauma patients or anyone neurocritical care patient. The complexity to offer the treatments was accentuated. The treatments should be different for each condition. Before wanting to improve the prognosis of serious neurocritical patient is complex. Getting the results is simple. We can buy a cheap monitor, but adapting the monitor with both monitoring tools, ICP or PTO2, implies first a leadership, implementation of a learning curve for all the staff, including the people for the lower staff in the hospital, in an ICU. The people with the wheelchairs need to know about the ICP, about the brain tissue oxygen monitoring, adaptation of the knowledge according to the functions of the personnel and the monitoring system, such as also a biomedical personnel. It's quite really important to introduce the people who knows about the machines, about the bioinformatics. The informatics may be necessary for the treatment of the patient. The implementation of a computer data collection system is quite important. There is a lot of information to collect and to correlate anyone with another one devices in relation with the brain. So if we develop a research in the lab in the beginning, and after go to the out part of the human, it's quite difficult, but need to help all the people of the staff, also the biomedical engineers, the analysis of monitoring graphs, identification of predominant secondary injury factors. There are a lot of factors inside the ICU, brain temperature, oxygen, CO2 response, that produce different tables and different treatments, the first body monitoring. And also we must to audit the auditing of results and monitoring of patients after the prognosis. The prognosis must be reliable in relation with the initial results in the lab. Monitoring cerebral oxygenation is not only a producer of electrons, it's a physiological trigger for the benefit of our patients with severe injury. Thank you very much for your attention.
Thank you very much, Jose, for your wonderful talk, and we are really proud that being a neurosurgeon and specifically neurocortical surgeon and critical care professor, you are so good and so much of knowledgeable in the neurophysiology part and given some inspiration from dog experimental to the human experiment. That's really called the bench to bedside. You have shown this concept of this conference. And thank you very much, Jose. And I over to the chairperson, Dr. Renuka.
Thank you,
Yes,
Professor
thank you.
George. Thank you,
Thank
Professor
you,
George.
thank you.
That was a very informative talk. This seems to be an invasive method of measuring tissue oxygenation from the brain, and somehow if you could come up with some non-invasive methods, it would be really very clinically practicable solution. And one more quote I would like to say here, which would be more apt for this talk. There is a quote that says that if you can measure it, then you can manage it. So if we can measure the tissue oxygenation, it would be a very helpful tool for the neurocritical patients also, and we can just extend it to the operating room anesthesia practice also.
Yes, yes, it's true. It's true. It was really important for me to go to Netherlands to learn something, and we must to apply it also in every. I want to apply the physiology in relation to brain tissue oxygen. We have a lot of secondary injury factors. You are an anesthesiologist, so you know the way to treat some patients is quite not simple. It's complex. But at this time in the world, they must start to treat the patients according with the prevention of secondary injury factors. This is the most relevant part of the treatment of patients like this.
And it would also guide to give a optimal FiO2, sir. We also know that over oxygenation is also a toxic thing to the tissue.
Yes,
So
yes, it's true.
We'll be having a good guide to give a adequate FiO2 to the patient.
It's true. It's true. But there is still controversies in relation with the best amount of oxygen treatment. For example, there are two different controversy. If we put a patient with for 50 minutes in 100% oxygen, and we must to translate the patients for the ICU to the surgical room, you can use the 100% oxygen.
Yes.
We don't know if in the ambulance transport, they can use the 100% oxygen, for example, for translate to the patient to the hospital. It's quite important because it's a really great moment. We see in the slides the initial hours of the trauma, the oxygen in the brain is quite low. So we must to define the treatment, the more important moments. We don't know exactly how amount of time and oxygen is necessary for the brain. There are too many questions. The oxygen needs the 100% oxygen, but in some areas of the hospital, we must use 100% oxygen. But in other times, it's not necessary to use 100% because induce superoxygen induce a lot of damage to 100% oxygen. So we don't know exactly the time in relation with the healthy brain. We must to go deep into research in the animals to see what is going on for the treatment. There are a lot of treatments we use in the ICU, mannitol, steroids, and they can modify the brain tissue oxygen. It's not completely the text finished. We must to learn about the lab from the research and again go to the clinical areas.
Thank you very much. Josh, thank you very much. Hope to see you here physically.
Okay, yes, I can travel. I can take a trip for India. It's not difficult.
Please visit India. And I was actually exactly Mexican border at El Paso for a long time. So
Yes,
I used to see the border and look at the Juarez opposite side light and all the things. And I used to remember that once if I able to come to Mexico, I able to enter. I was not having visa.
yes, it's possible. It's possible. Professor Pusal, you know, in Mexico we have a small a room on the view in the web. We have students, so we can prepare a trip to come with us to Mexico City.
Yes.
We can prepare a week. We have a week of experiment labs in a week. So we're teaching the students.
Yes, sure.
So we can pick up to Mexico City. It's quite easy for us.
Yes, we'll send some of the our neurophysiologists, neurosurgeons, anesthesiologists to your institution.
It's not quite easy. We have at this time I'm retired from the hospitals.
Yes,
I am working in my house.
Yes,
I am working in the areas of the university, the Mexican university. So we can use the areas of the Mexican university to prepare the reception for the next year.
Yes.
We're working for a week in the labs, in the animal labs. So we are teaching the students deep to insert how they can insert the devices in the brain, how they can read it, how can they collect all the information in a computer for several monitors. It's like a monkey inside a big banana, too much bananas. So it's not easy to quite for us, but we can prepare to time to come first. I want to learn about the ischemia vascular occlusion in relation with the attitude. It's really nice to see you.
Thank you, and thank you very much once again on behalf of the PSI and on behalf of the organizing committee. We thank you very much, and we'll send your citation by email. Thank you for joining us. Thank you. Have a nice day.
Bye.
Now, before going to next session, Professor Majid Diwan from Tulane University, New Orleans, let us the honor the chairperson of the two sessions, Dr. Sudipta Pal and Dr. Renuka. Sir, and Professor KK Diwan.
Dr. Majid Diwan.
Professor KK Diwan.
How are you, everybody?
Fine, fine.
I should say,
how are you?
Professor Amal is there. Okay. Now, good morning. I should say good morning, but it may not be good morning. It is good evening for you. Okay. How Professor Tifa is there? You know, everybody is there. Very all known faces are here. And
Yes.
Professor Alam is here. Oh, very nice to meet you all in this thing. Okay. Okay. How are you, everybody? I was listening to the session and it was very good. Last 2-3 lectures I heard from here. You know, okay.
Very good.
It's very good that I could join in this morning hours. You know, that's helpful. Okay, go ahead.
Thank you.
How's everybody there? Okay.
We are in evening hours.
Yeah. Okay.
I will request Professor Amar Chandra and Professor KK Dipan to honor the chairperson of the session, previous session. And like this. Wait. Holding in this way.
Thank you, sir.
Flower bouquet.
Citation? Citation. What's the citation?
Cloth napkin. But it will be nice, you know, just innovative.
Very nicely designed.
Thank you, madam, for acting as a chairperson. Your question was very good.
What is that?
So, Dr. Majid, how are you?
Achha, memento is given to him.
Hey, Sudipta,
She has got the memento.
the speaker, no? The speaker.
She has got the memento. Thank you, Dr. Renuka. Thank you very much. Thank you very much. Thank you. Just for the major now.
And leading the show. It's on, but still.
So we invite the chairperson of this session of legendary professor of physiology, Professor Diwan S.A. Majid, that is our young faculty member, Dr. Sritiratan Tripathi from Baharampur KM College. Professor Sritiratan
Good evening,
Tripathi, you are
sir.
here.
Namaskar, sir.
Yeah, over to Dr. Sritiratan Tripathi.
Nice to meet you with you, sir. After a long time, through virtual mode. Professor Diwan Majid, MBBS, MD, PhD, is a professor of physiology and director of phenotyping at Tulane Hypertension and Renal Center of Excellence, Tulane University School of Medicine, New Orleans, USA. He did his PhD from University of Leeds, UK. The research activities in Dr. Majid's laboratory at Tulane are centered on to elucidate the regulatory mechanism of renal hemodynamics and excretory function by vasoactive substances produced by endothelial cells, as well as the renal pathophysiologic mechanism of salt-sensitive hypertension. He received many awards and recognition for his scientific contributions, including Harry Goldblatt Award for Cardiovascular Research from American Heart Association, HMRS Award from American Society of Hypertension, and Professor S.C. Mohalanabi's Memorial Oration Award from the Physiological Society of India. Thank you, sir. Over to you, sir.
Thank you for inviting me. This, yeah. Have you? Is it okay with the sharing this thing? Everything okay? The slides comes out.
Yes, sir. It's fine.
Yes.
Okay. What about the sounds? Everything okay related to sound?
Everything is fine, sir.
Okay. Thank you. Thank you. And first of all, I should let me express my gratitude to the organizer of the PSI for inviting me for these talks. And also, I remember actually I joined first time for Indian Physiological Society meeting in Vijayapura. I think Dr. Kushal knows about it. Actually, I joined there in Alamin Medical
2003, sir. 2003.
2003. And
Then
I saw a
was
lot of...
Sir, then I was the student, research scholar.
Okay. I saw Professor Amal Chanda is there. Actually, I met him there on the first time. And thank you. And everybody, today I'm going to discuss about some of the recent finding in my laboratory, what is related to something non-deeping blood pressure. So if I go back to, I don't know, can I move forward? I don't know why. I can't proceed my slides. Is anything wrong?
No, Rakesh, just he is unable to proceed his slide by himself. उनको अपना नहीं हो रहा है. हम अपलोड कर देंगे क्या? नहीं, उनको नहीं हो रहा है.
उनका नहीं हो रहा है.
उनका नहीं हो रहा है.
He has uploaded.
सजेशन दे दो कैसे प्रोसीड करें.
You have to allow me to move it, or somebody has to do it.
Sir, you can switch your window. You should not see yourself. You see your presentation only. You see your presentation, then it will be, you go to full PowerPoint presentation.
Do it again. Go back.
Or you can go back.
First unshare and then share. Follow your
You go out.
Close, sir. Close the PPT first. I think close the PPT.
Sharing, stop sharing and.
Okay. I have to go back actually. Okay.
Yeah.
I have to close the PPT, you mean?
You stop sharing.
Stop sharing, sir.
Oh, okay. Okay. Now
Now you share again by using the PPT.
Now I'm sharing it.
Yes.
That's okay.
Change the slide, sir.
Scroll up, then you'll find me. Arrow button. No.
Soon. If I stop my sharing, then I cannot. What I should say? I should share it.
You share again.
Okay. No, it doesn't work like this. Huh?
Only press the arrow button. Sir, please only press the arrow button, sir.
Arrow button.
Either on the keyboard or here only, sir.
Arrow button. Yeah, that's yeah. Okay, now it is okay. Okay, thank you. Sorry for that mission. Okay.
No problem.
Regarding the deeping session, deeping is actually a very normal phenomenon. Blood pressure normally follows the circadian pattern characterized, which is actually every night time. It is 10% decrease in the blood pressure from the daytime. And this is actually active period in the daytime where the blood pressure is higher than the nighttime. And this may be different region. Most importantly, less activity in the night period. And also, which actually increases less activity in the night period means the sympathetic activity will be lower, blood pressure will be lower. Lying posture during the night period also helps to reduce the blood pressure by reducing the baroreceptor activity. And a lot of other circadian rhythms in neural and endocrine systems, which helps to reduce the blood pressure in the nighttime. And this is just like this here. Here you can see in the sleeping period, there is a ambulatory blood pressure recording shows that there is decrease in blood pressure in the nighttime. Okay, this is sometimes for some reason this alteration in this intrinsic circadian rhythm in blood pressure can cause this non-dipping in the night time. And this is called non-dipping blood pressure. And that happens in many cases in hypertension patient and also in different regions. A lot of other secondary causes can do this type of obliteration of this dipping pressure. Although we do not know a lot of things, what is going on, why this happens, but it is very important. We should see that there are a lot of factors actually blamed for this. One is the changes in the circadian rhythm and also changes in the autonomic nervous system. And most importantly, there is some alterations in the water and sodium retention process by the kidney during day and night time, which helps this leading to this non-dipping pressure. The most important thing is that in recent years, whenever there is ambulatory pressure recording and good recording was there, it was observed that particularly all the salt-sensitive hypertensive patients have got this non-dipping pattern of blood pressure. Also, there are different forms of secondary hypertension, and autonomic nervous system disorder also plays a role. But very frequently, you can say invariably, all the salt-sensitive hypertension has got this type of non-dipping pattern of hypertension. This is actually a reported study in 2010, and where it shows that you see that there's non-salt-sensitive patient and salt-sensitive patient. In that non-salt-sensitive patient, if you take salt intake low or high, that does not affect this dipping pressure in the daytime. This is daytime and this is nighttime. You can see there is a difference between this night and day during this non-salt sensitive fashion. But in the salt sensitive fashion, although low salt intake maintains this deeping pressure, the high salt intake obliterated this non-deeping pressure, indicating that these salt sensitives are always affected by this non-deeping pressure. Why it is important to us? Why we want to indicate this? In this, there is an intense interest in learning the mechanism or finding the mechanism, what causes this non-deeping. And what is the interest? Because non-deepers are known to cause higher cardiovascular risk associated with increased frequency of hypertension-mediated target organ damage, and has got the poorer prognosis compared to the deepers. And that's why identification of the mechanism is very warranted. And for this mechanism, when it identified, it helps to assess the risk of modifying salt intake to intensify salt restriction. It is another thing actually. In every hypertension, we randomly say that restrict your salt. But sometimes salt restriction also causes more harm to the patient than that. In this thing, if we can identify such mechanism which leads to this non-deeping pattern, we may identify actually the risk of modifying salt intake. And also we can investigate different secondary causes of hypertension and can assist the decision of choice and timing of the effective antihypertensive therapy. As I mentioned, the mechanism is not yet clear and not clear to the circadian rhythm of the renal sodium excretion differs between the differs and non-differs. Non-differs are usually associated with nitric oxide deficiency. This is a very common observation actually. And then in this, non-differs have got more sodium retention in the night, resulting and that results to the non-deeping BP profile. High salt intake also causing some impaired baroreflex function. We have shown that those who have taken high salt, they have baroreceptor functions is impaired. And that might help to alter the autonomic nervous system in the nighttime that leads to the sodium excretion leading to non-deeping pattern. And most importantly, recently, that renin-angiotensin system plays an important role in this circadian rhythm. And non-deepers, urinary excretion of angiotensinogen is increased in the nighttime. That was reported from our lab and also another lab from the Japan in this 2017. And there is a report also earlier that bedtime administration of angiotensin receptor blocker in hypertensive provides higher efficacy compared to the morning treatment. That also indicated that the changes in angiotensinogen or renin-angiotensin system during nighttime may have some contribution here. But when angiotensin, we consider about angiotensin-dependent hypertension, this is intensely related with the immune system also. That is, inflammation is one of the marker or one of the associated event with angiotensin 2 induced hypertension. That actually review was published by Dr. Nawar in our department in 2018, showing that angiotensin 2 increases also influence immune system that releases some cytokines for inflammatory cytokines and causing imbalance in the inflammatory and anti-inflammatory cytokine. That also, again, vicious cycle increases the renin-angiotensin system and also causes hypertension, and that leads to some hypertension-related tissue injury. So with this thing, we thought, we have seen that high salt intake, what actually in different experiments, particularly in the animal, we have shown that high salt intake itself does not cause any change in the blood pressure, unless there is a condition is there which actually causing nitric oxide deficiency or some other form of oxidative stress condition. Salt-sensitive groups have lower nitric oxide bioavailability than the salt-resistant group. And salt-sensitive hypertension is now considered as a chronic inflammatory condition. And how this happens, high salt intake it's through this osmoreceptor function induces an immune mechanism that actually activates this MPS cell, mononuclear phagocytic system cells, and that is circulating throughout the body, including the kidney. And when it is kidney, it releases TNF-alpha, which plays a very important role in salt excretion in the kidney. And in my lab, over the years, last decade, we have developed, we studied with TNF-alpha, and we have seen that TNF-alpha usually acting on the kidney by two different receptor types. There, TNF-alpha has receptor type 1 called TNF receptor 1 and the TNF receptor 2. And those two receptors have got very distinct function. Receptor 1 activity, mostly hemodynamic and excretory function, it causes natriuresis or diuresis. And as it is causing natriuresis and diuresis, it participates in a counter-regulatory mechanism opposing salt excretion. So salt retention, and then it acts as a protective, practically in minimizing the blood pressure response to angiotensin II and nitric oxide deficiency. But on the other hand, TNF receptor 2 activity is involved in inflammatory process like renal regenerative function, cell proliferation, macrophage infiltration, and a lot of other related to this. So with this thing, in a series of experiments, I think from 2008, you can see, up to we have done different studies in different models where the plasma TNF-alpha level increased. All this thing increased, you can see there is an increase in the sodium excretion, and sodium and fluid excretion still increased. And all this effect was done, we have shown that these are involvement of the TNF receptor 1. So this experiment suggests that activation of the T1 receptor 1 by TNF-alpha plays a counter-regulatory mechanism to minimize the salt retention responses to nitric oxide inhibition or other oxidative stress conditions like elevated angiotensin II level and saline. And recently we have shown saline volume expansion also leads to this. The natriuresis caused by saline volume expansion also caused by this TNF-alpha released by from the system. And recently we published this thing that even in TNF-alpha receptor blocker, in the knockout mice, which has got knockout for TNF-alpha receptor 1, has got higher angiotensin response sensitivity. That means the blood pressure changes due to 4 weeks of angiotensin treatment shows that higher blood pressure in the TNF receptor 1. And also interestingly, we have seen that angiotensinogen excretion by the kidney is higher in TNF receptor 1 knockout mice, indicating that TNF receptor 1 exerts a protective role by maintaining this protective role by the hypertension induced by angiotensin II and high salt intake. We also shown in this TNF receptor 1 knockout mice, and when it is given with the nitric oxide deficiency, either by giving L-name or by studies done in the enos knockout mice, in both cases we have seen TNF receptor 1 is down-regulated in this mice. But high salt intake itself, you can see very enhance this TNF receptor 1 expression in the kidney, indicating that this is one of the TNF receptor 1 plays a very important regulatory role or protective role in the condition of nitric oxide deficiency, and that minimizes the sodium excretion when it is downregulated. It is minimizing the sodium excretion during high salt intake, leading to the development of salt-sensitive hypertension. So, as we have seen that circulating TNF-alpha induces natriuresis by activating receptor 1 in the renal tubule. That indicates its protective function during high salt intake. Renal angiotensinogen production induced by the angiotensin treatment also shows the increase in TNF receptor 1 knockout mice. That also indicates the protective function of this receptor in suppressing the angiotensinogen formation. And this protecting function is shown to it is compromised in NO deficient condition. So this also helps, that's probably reduces this, so actually sodium excretion, and more sodium retention occurs, and that leads to the salt-sensitive hypertension. This non-deafing BP pattern, the common features in salt-sensitive hypertension. So, and also this salt-sensitive hypertension is characterized by enhancement in internal formation of angiotensinogen and also TNF receptor. But we have shown the TNF receptor 1 activation by TNF-alpha plays a protective role in suppressing the internal angiotensinogen formation. So that might be possible in that diurnal variation of the generation of angiotensinogen and TNF-alpha may alter this circadian rhythm, and that can influence the non-deafing blood pressure pattern in salt-sensitive hypertension. But however, these interactive roles of angiotensinogen and TNF-alpha is inducing this non-deafing BP pattern is not yet clearly understood. So we planned some experiment to examine the hypothesis that non-deafing blood pressure is resulted due to abnormal circadian pattern in inducing this angiotensin formation that is caused by inverse diurnal variation in TNF-alpha production in response to high salt intake. Then the main aim of the study was to determine the diurnal variation of this angiotensinogen and TNF-alpha formation in the kidney in salt-sensitive hypertension condition induced by chronic administration of angiotensin II with high salt intake in mice. And the experimental plan was done like this, that we gave the mice with a high salt diet, which is contained 4% of sodium chloride, with the administration of angiotensin II at a lower dose, 1 microgram per minute per kg. And we compared these responses with the sham-operated mice, which has got normal salt diet, normally which is 0.3% of the salt. And as the mice was nocturnal in nature, we have to consider here all this, the night time should be considered as the active period in mice, and daytime should be considered as inactive period. So mice is a bit different than, what is that called? It's actually the inverse actually than the human subject. Nighttime is an active period, daytime is inactive period. So the circadian rhythms in urinary parameters and blood pressure, all are assessed in 12 hours changes. The active night period are considered from 7 p.m. to 7 a.m. and the inactive day period was considered 7 a.m. to 7 p.m. And what we have seen in these two groups of mice, what the normal salt intake group and the angiotensin II and high salt intake group, you can see here that this normal salt group within this 4 weeks, we can see that the deeping pressure, that means the difference between night and day period, deeping pressure is maintained in this in this group up to even 4 weeks of this day. But in in angiotensin to high salt intake, you can see the blood pressure was increased significantly in angiotensin to induced mice. And gradually you can see this dipping pressure is obliterated. After 4 weeks, there is no dipping pressure in this mice, indicating that the dipping pressure associated with salt-sensitive hypertension is altered in this mice. Most important, when we measure the angiotensinogen, urinary angiotensinogen excretion, in this night active period group of mice, in the night time, you can see even in the angiotensin 2 induced mice, there is a tendency of increasing the angiotensinogen excretion than the normal salt diet, but it is not statistically different too much. But on the other hand, in the daytime, that is inactive period, you can see the angiotensinogen excretion rate is increased in angiotensin treated mice than the normal salt one. And inversely, interestingly, in the active period, there is increases in the TNF alpha level. You can see very in the 4 week step, there is much increase in TNF alpha excretion in the urinary excretion rate than the normal salt group. But on the other hand, inversely, in the inactive period, this TNF alpha levels does not increase much, only a little bit, which also do not show any statistical differences. And on the same hand, in the plasma, when you measure the TNF alpha level in the plasma condition, you can see in the active period, there is increase in TNF alpha in the night time. But in the daytime, inactive period, that means always inactive means consider this day is human. If you want to interpret it, the human says it's at night time. But here is an inactive period. There is a tendency of increasing the TNF alpha, but not much statistically different. The same way, other inflammatory cytokines, but on the other hand, like interleukin-6, there is not much difference between this active or inactive period. There is no much changes during salt intake. And another anti-inflammatory cytokines like IL-10 also showed the similar pattern in TNF alpha also, showing that angiotensin treated mice, active period, there is much increase in IL-10. The similar also, there is also increase in inactive period, but it is less than the active period. In relation to the sodium excretion, on the other hand, also shows that angiotensin treated and high salt mice, there is much increase in sodium excretion in the active period, that is in the nighttime, than the inactive period in the nighttime. That is, we understood that we actually explained that because TNF alpha is secreted much more, and that TNF alpha is a natriuretic agent. It causes this increasing the sodium excretion in the active period, and inactive period is less because TNF alpha excretion is also less. Most strikingly, interestingly, that proteinuria, the urinary albumin excretion, was very high during the active period in the nighttime than the inactive period in the nighttime. Although there is proteinuria, but it is less than the active period. So another interesting thing that, we measure the tissue collected during the nighttime period and also tissue collected inactive period from the kidney. That means some of the mice were sacrificed in the nighttime and some of the mice were sacrificed in the mid-daytime. And the tissue analysis shows that TNF receptor 1 activity is significantly higher in angiotensin 2 treated mice during the active period. But there is also some increases, but it's not very high, and statistically is very borderline statistics here. So collectively, these data indicate that increase in TNF alpha generation, you can see the decreases in internal angiotensinogen formation during the active period. And inversely, the decrease in TNF alpha generation enhances internal angiotensin production during the inactive period. And that, we think facilitates a non-diffing blood pressure pattern in salt-sensitive hypertension. So in things, we can postulate a mechanism here. The non-diffing pattern of salt-sensitive hypertension occurs in the condition of oxidative stress, like nitric oxide deficiency or renin-angiotensin system increases. You can see in the active period, TNF alpha is more, formation is more, TNF R1 expression is more, and that may be that both activation, actually this one, leads to less angiotensinogen generation by the kidney, that causing less salt retention, and that also leads to less extracellular volume, and blood pressure becomes actually less in the thing. So on the in the daytime, active time, in the inactive period, the reverses happen. This TNF alpha formation less, TNF R1 expression less, and that leads to more angiotensinogen generation, more salt retention, more extracellular volume, and the blood pressure increases. And this pattern changes from the diffing to the non-diffing pattern. So take your message from these results, that these results have identified a role for TNF alpha, TNF R1 axis in the pathophysiology of the non-diffing BP pattern with salt-sensitive hypertension. And this may help to develop an effective treatment strategy in salt-sensitive hypertension that can be related to the specific activation of TNF receptor 1. In this point, there is no drug available which can directly stimulate renal receptor 1 activity. We have a lot of drugs in the market that shows that they inhibit the TNF receptors, either both TNF1, R1, or R2. Also, more commonly available TNF receptor 2 blockers, which prevent the inflammatory process. But there is not much, we have seen anything related to the TNF receptor 1 activity. But with this thing, if we can proceed further, these results can prevent the cardiovascular mortality and morbidity by reducing the target organ damage incident. And we should have great impact in the lot of socio-economic burden on population health. With this thing, I will just acknowledge a lot of people are behind this thing from different times, a lot of postdoctoral fellows, research fellows, and collaborators. And with this thing, I last over to mention that Professor Kushal Das, and I remember very fondly the Professor Biradar, those who are actually started a collaborating project related to this angiotensinogen and the variation, diurnal variations of this angiotensinogen measurement in fashion. I don't know how far we can proceed, but after Sir demise of Professor Biradar, we have not proceeded further in this project, this clinical project. With this thing, I just thank everybody for your attention here. Thank you.
Thank you, Professor Majid, for outstanding and very, very original research which you have presented. And we are honored. The Physiological Society of India is honored, and organizing committee is really honored to have you. And it's wonderful that in your presence there, Professor K.K. Deepak is there, Professor Amar K. Chandra is there, and all the people there in presence of them. You have delivered the lecture. It is online. We wish you to see you again here. And I'd like to inform that the collaborative project which I have taken, there are two compartments, the human and animal model. Animal model actually given both of us, myself and Professor Majid, one PhD student. Dr. Gauhar Banu did PhD under me and Professor Deepak from this university, and the both guidance. So this is one of the animal model production was very good than the human model. It was because after the expiry of Professor M.S. Biradar, the clinical side, the sample numbers we are unable to manage because the clinicians were not there to actually to do the work. But definitely we'll continue, but still we have the data and some data will be more corrected, but let us conclude it, and some data I have already sent you. And we have had 2 publications also in this regard. And thank you, Professor Maji, to remember that, and we are all honored. And over to Chairperson, Dr. Shri Tripathi.
Thank you, sir, for your excellent presentation. In this experiment or investigation may help to develop effective treatment for this clinical condition by reducing the frequency of hypertensive target organ damage. Thank you, sir. If any questions?
I think the Professor Majid, if he was personally would
Yes.
have been here, we would have not
You
spared
can
him
ask,
in the
we can
dinner.
directly contact with.
We are going to banquet dinner now.
Oh, I see. Okay, okay. I missed it. I missed a lot of my very friend. I can see Professor Deepak, Professor Walchanda. Yeah, okay.
Thank you for your excellent presentation.
Yes.
The idea is very good, excellent. However, we are missing you in the gala dinner.
Okay. Thank you.
See you shortly. And physically, Professor Das. See you shortly physically in India.
And I'd like to inform you, Professor Majid, that Professor H.C. Mohanabi's memorial oration, which you have delivered, now this year it is delivered by Professor K.K. Deepak.
So that's why actually congratulations. Actually, very good. That was I saw that was Deepak. Very good. Thank you. Thank you. I missed your presentation. Actually, that's what it's a dead of night. If not actually dead of night, I could have been joined and listened to your talk.
But in the night, you very early night. So it is in YouTube. We will send you the link. You can see it and his lectures. There is no doubt.
I have a suggestion to make.
Thank you. I would appreciate it.
Yeah, I have a suggestion to make here. There was something common which I presented today clearly. When you do a renal transplantation, this BIS, bioflex sensitivity, returns back. So we were wondering how. So this must be putting back the whole system to the back because there is a link between the renal system and cardiovascular system to the autonomic nervous system.
Thank you. Actually, this is very important actually to study. And I know when I was talking about autonomic nervous system, I was thinking about your study. You could do something study over the day and night difference in circadian rhythms in this baroreceptor sensitivity. That's good. Okay. Thank you. Thank you very much.
Nice to meet you, sir.
Yeah, we will send your citation by email.
Thank you.
Thank you.
Okay, I would appreciate it. Okay. Yeah.
You start with a very simple thing, and gradually your lecture becomes more and more informative, more complicated, and therefore excellent.
That is amazing.
Initially, it is quite easy and understandable for all. But later on, gradually, when you go deep, it becomes deeper.
I hope the students and others who join actually understand it properly. Because that's the way actually we have to develop our research thinking. Actually,
Enter the lecture will be in YouTube. Enter the lecture will be in YouTube, and I will send the link once it is ready. We will send the link. Your student and our student all can be circulated. Now it will be on our university website.
Thank you. Actually,
Have a nice day. And convey regards to Nina Bodhi.
Yeah, okay. She's actually early morning. She's she's in bed actually. We'll go. I think we started. It's a cold season started here, and suddenly from yesterday in New Orleans area we are experiencing very cold wave coming from the north, and that's everything suddenly cooled down. Yeah.
Okay.
Take care. Thank you, everybody. Thank you, everybody here present. And I say, I really miss everybody.
We do.
We also, sir.
Okay. Thank you.
Bye-bye.
Thank you. Bye. Bye.